Can you hear us all here? Good.
Yeah.
Is that any better?
Yes.
Can you hear on the screen? Excellent. Good. Let's get started. So, welcome to our South West Peninsula board meeting in public. Just a bit of housekeeping as we start. We're going to try and change a little bit of the timings of today around. So we're going to start now and finish at 1 o'clock. And then just for colleagues who are hopefully all going to be here this afternoon, we're going to have a half an hour lunch break and start at 1:30, because there's a fair bit to get through this afternoon. Okay, just so everyone's excited. Still try and have you away this time by 4, which is a luxury because we finish at 5. So enjoy the time off. Okay, so let's get into it. So welcome, and let's start with the apologies. So we've got Steve, Chris, Piers, Smitesh, and is there anybody else that we feel who should be here who isn't? No? I don't think so. Okay, so let's move straight into it. Declarations of interest. Any to raise? No? Okay, thank you. We're going to go to public questions next. We have a question that is it John that's answering that? John, if you're kind enough to answer.
Thank you, Chair. We had a question from Dr. Terry Elliott from the League of Friends at Ilfracombe. The question is, please can you make the public aware of the terms of reference for the minor injury service review, when the review began and will finish, and when will the public be consulted on any proposed changes, bearing in mind that the Ilfracombe Terrell Hospital MIU was removed without any public consultation. So I'd like to thank Dr. Elliott for that question on behalf of the League of Friends, actually. We do recognise the concerns following the closure of the MIU and the impact that has had on the local community. We will give a full reply by email to Dr. Elliott. But from the board, I'd like to acknowledge that a review of minor injury and urgent care provision across Devon is an absolute priority for this integrated care board. The review has been undertaken in the context of national expectation for NHS on a clear direction for the development of UTCs. For this reason, the review will look not only at MIUs, as we will consider urgent care provision as a whole, including primary care, community care, minor injury units, UTC, 111, ambulance service and emergency departments. NHS Devon will not make any decision about next steps until it has concluded this review. There are no current proposals for any changes. Thank you. Okay, thank you. Minutes of the previous meeting on the 27th of November. Are you happy for me to record them as accurate? Lots of nodding going on. Lovely. Thank you very much indeed. Philip, if I could just turn to you on the updates on the action log. What would you like to tease out for us there?
I propose that, unless anybody's got any concerns about the actions which are proposed for closure, that we focus on the actions that are in progress. So I think the first question is, does anybody want to raise any concerns about the proposed actions for closure?
No.
No. I think rather than going through the actions which are in progress, I think it's worth flagging that certainly there are a number of actions relating to board development sessions and committee membership and various other pieces of work that will be, I think it's worth identifying them, will be caught up in a corporate governance review that we're undertaking. Currently we're working with our internal audit colleagues across both ICBs and they will be discussing committee effectiveness issues with the chairs of our committees and working on our reviews of our conflicts of interest registers or our policies and so on. We're aiming to bring that to the board in May, together with updated board forward agenda plans and development plans as well. So it's a catch-all update for a number of items that are being held up by that work. But I think once we've completed that work, it will be in a good position. In terms of other actions, I suggest that if anybody has a particular issue that they want to hear more about, that they flag it and we can deal with it that way.
Any other questions, observations on the action log? No? Okay, let's move on. So let's move on to the patient vignettes. Where's Lucy? The trouble sitting here. Lucy down the far end. Lucy, we're in your hands. Please take us through it.
Thank you, John, and good morning, board. Today's theme of our patient vignettes is children and young people, and I'm really pleased to see the span of films that are showcasing what's going on across both Devon and Cornwall. There are 5 films that show how ICBs across Devon and Cornwall are improving outcomes for children and young people, which really align to the NHS 10-year shifts, both from prevention, early intervention, digital innovations and partnership working, and bringing care closer to home in our communities. The first film is about oral health in Devon, with the Open Wide and Step Inside programme for Year 2 pupils for the next 3 years. It's a real practical, evidence-based approach. A similar Big Brush Club scheme is also running across all schools in Cornwall. We understand that dental is a #1 priority for our population, so it's really good to see this happening and really involving that prevention agenda for our young people and the next generation. The next film focuses on Lumen Nova. It's a nice recommended digital therapeutic supporting children with anxiety. Over 1,000 children in Devon have already accessed it, and it's proving to provide real strong outcomes for children with SEN and for boys, demonstrating the value of accessibility and early mental health support and the digital innovations that are available to us and for many young people across the ages. The third film from Cornwall showcases community appointment days for an ears, nose, throat and child-friendly clinic at the Jungle Barn in Hale. I love that video, it's just so great seeing those smiles on people's faces, both parents and children alike. The fourth film captures the fantastic work of Healthwatch Devon, Plymouth and Torbay's engagement for the NHS 10-year plan with young people, and particularly it was great to see the young people champions and reporters being involved in that, which has led and shaped not only national plans but also the local health and care strategy for Devon. The final film highlights the PINS programme in Cornwall, which is supporting neurodivergent children in mainstream primary schools. Over 60 schools are now involved, and it really just shows how together as a system there is listening, prevention, early and reducing inequalities in our work. Thank you everyone who featured in those films and for those involved in delivering this work, and it would be great to see some of this innovative work evolve and be delivered across our cluster to support our next generation going forward. Thank you.
Any thoughts? Frank?
I looked at them all this morning, and I'd just like to thank you for having a focus on children, because they are absolutely the future for us, and we've got to get it right. The other thing that came across really, really clearly was this is about the new model of delivery. This is about social medical models rather than just traditional medical models. And it is about engaging with our communities in a very different way. So I think the whole package and looking at them all together was just fantastic. Thank you.
Thank you, Martin.
Thanks, John. Yeah, I'd sort of echo that too. It's great to see, I suppose, particularly the outpatients outside of the main sites and how well that worked. Really great to see the children so excited and happy to be doing that and really bought into the process. Also great to be seeing children invested in terms of dental health futures and trying to get people things right at early days. I think on the counter side, John, I just remind us that last time, we did talk quite extensively about the benefits of having some slightly more gritty type of vignettes, and I still didn't have that this time. I suppose as an example for this one, it might be good if we were concentrating on young people to say, what's it really like to be waiting 2 years for a diagnosis for autism or neurodiversity, something like that. Something that just gives us some lived experience of part of the issues that we have to type of address as a board.
I think that's a really fair challenge. I think over the years we've balanced it, but I think there's a grave danger of actually, not a danger celebrating good stuff, but making sure that the board is really alerted through this type of mechanism of some of the really challenges. I can't see you, Lucy, sorry. If you could just lean forward a bit. If you could just help us make sure that we've got some of that grit in the oyster as we go forward to help us. I'm thinking some of the things that came out of these things in former lives in terms of falls cars, x-rays cars. I'm thinking about the community health work. They came from patient vignettes that actually showed us, as Martin's saying, these are real issues. And then the board said, we've got to do something about that. So if we could just balance, that would be really helpful. Thank you. Tan, did you want to add something?
Yeah, I think just to add to what Martin's saying and what you're saying, at the equity workshop that we did, we looked at the fact that nearly 4% of Cornwall's children are actually waiting for an assessment. Okay. So actually, we need to move away from delivering services where health professionals feel comfortable to places where the people that are receiving them feel comfortable. And I think that's a really great opportunity there. So great showcase here for that.
Thank you. Lincoln?
Yeah, just wanted to compliment the ICB on commissioning for supervised toothbrushing across Devon. I think that's been a real win for us. We still have problems clearly with dental access, but we have a really strong preventative program across the 3 local authorities in Devon. And I think that's really a good thing that we're doing what we can in that space. In terms of the autistic spectrum, clearly all across, we have a problem. It is a key issue with SEND. I think that certainly in Torbay, and I think the other local authorities as well, we have a graduated response. And I think it's important that we do not just wait for the diagnosis, for the label, but that we have a culture of responding to need, because that's what the parents tell us. So while we're waiting, there's a lot that can be done to respond to what are the issues for that family, for that child, while we're waiting. So yes, we still need to get the label, because certain things depend on that, but there is a lot more that we can do in terms of our culture of support.
Thank you for that. Before I bring in Lopa, just to give you a heads up, Penny, I'm going to turn to you in a second. I'd like you just, on the springboard of this whole genre of children and young people, given the statutory duties we have, a lot of that falls into your seat, is how you can assure us that we're actually dealing with that in Devon. And Ash, yes, from your seat, from Cornwall, so I can just turn to you two in a second and just get, there's something here about the assurance that children and young people is being dealt with in terms of our statutory duties. I just want to just get that out as we're in the public domain. Lopa.
Thank you. I thought the vignettes were wonderful. The only thing I would say at the moment is we as in all of us are giving slightly confusing messages, particularly about online. Colleagues will be aware there's a consultation on online safety, which is looking to ban the use of phones in school time, for example. And I just wondered, Lucy, if there's a way of asking our young people for their perspectives, the ones who've been involved in the videos that you've shown, just to get a rounder perspective, particularly around mental health. Thank you.
Okay. Let's go Penny first and then Ash.
Sorry, Chair, could you repeat that? I was thinking about the statutory duties.
No, I was asking you, did you want a response?
No,
Yeah,
thank you.
So my question is about our position on our statutory duties with children and young people.
Yes, and so as you know, Chair, we're in the process of a consultation, so just be slightly cautious around some of the things. But one of the key pieces of work is making sure that we're doing sufficient gap analysis against our future intended structure to deliver on those statutory duties. And you will be aware, Chair, that subsequent to developing those structures, we were in receipt of 4 further ICB blueprints. So that's a piece of work Philippa and colleagues are taking forward, and that will inform the consultation feedback. What I feel comfortable about talking about in this arena is what is the statutory duty absolute, who can complete that work, and how is that work done in the frame of really effective multi-agency working. We know the gains for children are not to be, if we talk about neurodiversity, autism, for example, we know the power is early intervention and effective multi-agency working, so that we become a needs-led system rather than a diagnostic-led system. So that's where some of the work that Lincoln has just talked about, it's about how do we systematically, because those vignettes point to pockets of really good practice, how do we systematically, across our big footprint, apply what is recommended good practice in a really efficient, clinically optimised and productive way. And one of the things, Phil, we've been working on, and you've just written to me actually, around how do we effectively commission an integrated diversity assessment pathway. And that really requires effective work from primary care, with voluntary sector, right the way through. Diane and I have had a conversation in month. How do we start to take a really chef shift left approach to this. So I think it's an example. If we look at children in Devon, up to the age of 25, they account for 30% of our population.
Right.
The impact of waiting for young people impacts on their life, but also social impacts for life about our society.
And you're comfortable that the commissioning intentions that we as a unitary board are taking for Devon, and I'll ask actually the same in the question in a moment, for children and young people, our commissioning intentions are focused and addressed on our statutory duties?
They are, but we do need, in a world of where we talk all age, which trips off the tongue, there are cohorts between an all-age approach that have specific needs.
Okay.
So I think we need to be really specific, and the work we're doing around INAP, for example, will answer that.
Okay, thank you. Ashma, Cornwall and Isles City perspective, please. Children and young people.
Yeah, we recognise this to be a challenge faced not just in Cornwall and the Isles of Scilly, but of course nationally. For us, we've undertaken harm reviews of anyone waiting on the waiting list, but more than that, we've also implemented waiting well, as we're fully committed for that. Those families that are waiting on the waiting list, it's just not suffice for them to be left without that support around them. So this initiative has been very well received. We're continuing our development with that, and we're now looking at additional workforce and navigators to support with, to provide support for those families who are waiting. And we're also looking at the referral process and seeing how we can stream that to make sure that those that desperately require the support that can actually access that in a timely fashion where we can. And in terms of moving forward, that piece of work is underway with our commission intentions also.
Thank you. I'm going to bring in Anne-Marie. And Anne-Marie, this is a topic that the 4 chief executives that I met with during the week, hence one of the reasons why I'm sort of teasing it out. So I'm delighted that you wanted to put your hand up and have a comment. So please, what are your thoughts?
Thanks, John. And clearly you asked a really, really broad question, and the vignette in this regard does demonstrate some really good work, but I think it's really important for the board to hold in their minds, and particularly in terms of SEND local area partnerships, of which is a joint inspection of local authorities and the ICB, that certainly across Devon, the inspections have found that there are widespread and or systemic failings in all of the Devon authorities, with re-inspections coming. And I just pulled up as you were talking in terms of the Torbay latest SEND inspection report, and that says long waiting times for health assessment and diagnosis, coupled with gaps in provision, often leads to children and young people's needs becoming greater while they wait to get the right support. So going back to the point that Lincoln made in terms of, yes, there's the diagnosis, but there's the waiting well issue, that actually we need to ensure that we are continually focused upon. More widely in terms of children, the ICB is a lead safeguarding partner and has the statutory responsibilities under working together. And again, and there are variances between the councils in terms of the delivery of those services, but it's widely recognised that particularly those in Devon are particularly challenged with a commissioner, in Devon County rather, are particularly challenged with a commissioner and ministerial oversight, and that requires intense partnership working with the ICB. I think it's therefore a very simple question to say, are statutory duties being met? How well they are being met is a very complex answer, John.
Quite right too. And one of the things I was going to come on to, and I'm going to ask Philippa to say a few words in a second, but I'm also going to ask Susan and Libby to say a few things here, because there is something here about our statutory duties, and there's something about recognising, as you've just said, Anne-Marie, and I completely agree with you, we need to find, particularly in Devon, how are the working relationships at executive and at non-exec and political level actually working. And as we're getting clearer, Anne-Marie, on the desire from the councils in Devon to want to work more closely individually rather than as an integrated care partnership, and I'll ask Mary to have some thoughts about that in a second, is that we need to set up, maybe more specifically in Devon, what are the executive working relationships that we've actually got with the chief executives in the 3 councils that we've got, to make sure that not just children and young people, but I wanted to use children and young people as the The thing that absolutely binds us together, not saying the adults don't, but this is a big issue for at the moment. How are we going to make sure that we work as a system and partnership working relationships? That there are gaps at the moment in our working relationships. How do we make sure that with Anne-Marie, with Tracy in Plymouth and with Donna in Devon County Council, how are those working relationships at executive level going to be worked out, and how are we going to actually do it as the political side along with the non-exec side? And the same thing actually goes with Kate Canally in Cornwall and Susan, the relationship that we've actually got there, which I think is in a different place, but we can always improve. So I'm going to come to Philippa first. What would you like to add? And then I'll come to Libby and then to Susan.
Yes, I think so Penny's touched on it, and I think it's worth just flagging we will be bringing a formal assurance report to the board on how the new organisational structures will be delivering our statutory functions, and that's been requested by NHS England as well, so that they can have assurance from our board on that. But my second point is the point that you've already made, John, which is that absolutely has to be underpinned by working relationships as well. It's not just about structures, it's about how we work together. Correct. And that's only something that we can start to push forward properly once we've got those structures in place and the roles filled.
Yeah, fine. Can you help us on the Devon side, please, Libby?
Yeah. Yes, of course, Chair. I think it's fair to say we do have partnership working arrangements in Devon at the moment, but I think, as has already been stated, there is challenges within that. Obviously, as we move into our new organisation as a cluster, and the challenges of delivering a very complex plan, we need to review those working arrangements in line with that. So I think that there is absolutely a commitment to do that. Myself and my CEO colleagues and all the councils are meeting regularly, informally, as well as the formal arrangements to work that through as the new structure is put in place. So I think an important message for today is that we recognise that we can't do this alone as any partner in the system, and therefore we are going to need to ensure that the arrangements going forward enable us to do that in the most effective way.
So if I could ask you, with the board's support and your support, before I bring in Frank and Susan, can you, for the next board meeting, make sure that you've spoken to each of our chief executives in the councils and made sure that there is a collective union as to the executive group of working that you want? Anne-Marie, does that work for you as a suggestion?
Yeah, and it goes strong with our discussion with the others earlier this week that we needed to do that, so absolutely.
Very good. So you're happy to come back with that? That's Libby's charged with that.
Absolutely.
I just want to go to Susan first, and then I'll bring in colleagues. So Susan, I'd like you to just do Cornwall and the Isles of Scilly first. How do you feel those executive relationships are working, and what can we do to improve them?
Thanks, John. So, of course, we've got good working relationships both with Cornwall Council and the Isles of Scilly Council, and using the governance frameworks, particularly around safeguarding, which is the leading safeguarding partnership, as well as the designated safeguarding partnership. So that's with the chief executives of the DSPs, and usually the CNOs are the LSPs. So we've still got that framework in place. Really important that we continue to do that, because that closes off any of the loops and the gaps. With respect to services, I think, Anne-Marie, you mentioned SEND inspections. We've had our own down in Cornwall, very much seen as a collaborative inspection between health and our council colleagues. We're very aware of where our issues are, particularly for that group of children and young people around speech and language, as well as neurodiversity, which is what's prompted us very much to concentrate, put a spotlight on those waiting lists for all the reasons Ash has just said. I think that the bit that that Libby's touched on, I think Penny also touched on as well, is that important mapping, because of course we're going down to a much smaller workforce within the ICB. So how do we ensure that we are present at all of the meetings that are relevant to children and young people, that's not diluted, but we've got the right skill set around the table? So we are currently doing a mapping exercise across Devon and Cornwall and Isles of Scilly to understand not only the meeting and the governance arrangements, but who's best placed to be in those meetings with the appropriate delegated responsibility. So incredibly important part of our statutory functions as an ICB, and we'll continue to work with our local authority, which is the only way we can ensure that all of our children and young people are absolutely seen as being equal to adults and older people. Thank you, Chair.
Thank you. So if I could just ask the same as I asked Libby for Devon. If I could ask you just to report back at the next board meeting that you've spoken to Kate Canally, and if there are any gaps in executive working relationships, that ideally the two of you agree on what the solutions might be, if that's okay with you. Frank.
Thank you, Chair. I'd just like us to think slightly beyond organisational responsibility and about people, because a lot of these children go off radar. I go into 2 schools to welfare meetings. Last year, in one of those schools, 3.5% of their school population became electively home educated, largely because of the failings of us to meet their needs and get them seen in neurodiversity clinics. That impacts on them, it impacts on their families. I then followed it up with Devon County Council to find out how many across Devon. Last figures were in 2023, and that was over 2,000 children electively home educated. They become off radar when that happens. And we are one of the highest in the country for electively home education. So it's not just about the organisational responsibility. We really do need to focus on people.
Okay, well said. Neil.
Picking up that point, taking it back to ground.
Can you hit the button? Sorry. It's all right.
Okay, sorry. And taking it back to ground level, the impressive thing about the vignette with the PINS service was that it was an example of personalised care being exercised by the teachers in the school. When I used to be a school governor, so often you'd see the SENCO dealing with everything, whereas actually it was everybody's business in the school when children had problems. And I think, well, I just want to make a point that this looks like an example of what you call an activated workforce with a common purpose. Okay. And that is something we're going to need in terms of transformation. I just wanted to make that point. When you see things working like that, they're working for people and what they really need.
Quite right too, quite right. Anne-Marie.
Apologies, just really quickly, recognising we're in public and I wouldn't want it to be misunderstood or misinterpreted. There was a comment just in terms of elective home educated children go completely off radar. So when children are electively home educated and the numbers are rising, they are rising nationally. It's a significant issue because it's absolutely accepted that the best place for them to be in is school. But we are increasingly told by parents that they have no choice other than to electively home educate because of the failings. However, local authorities do have an ongoing responsibility to monitor children who are electively home educated. So it is not that they go completely off the radar and are unknown, particularly if they are subject to child protection plans. There are very enhanced monitoring arrangements, but they are reviewed on a bespoke arrangement depending upon the assessment of their circumstances to assure that they are receiving a level of education, and local authorities can and do issue school attendance orders if the education is not deemed to be to a sufficient standard. So I wouldn't want it to be misinterpreted, John.
No, and that's an important point. Thank you. Penny?
So in brief, just coming in behind that, and I present this as an example of really effective multi-agency working. So in the ICB, I'm the designated lead for the delegated safeguarding partnerships. I've arranged for an agenda at the next meeting for Devon County Council, or the Devon County Council footprint, to have a report from the head of the virtual school. And there we will look from a multi-agency perspective, both reasons why those children are electively being home educated, also the contribution from health, police and so forth. So I think that ties that together, Anne-Marie, around why those multi-agency arrangements are so important.
I can see Anne-Marie nodding.
It is an issue, but that's where our partnership working really impacts.
Thank you. So Lucy, I know you know this, but do you see the value of these vignettes in terms of the discussion that then prompts? And I'm hoping that even though the vignettes went maybe too gritty, I think that conversation led to some really important points coming out and some conclusions where I hope with the chief executives of Cornwall Council and the chief executives from Devon Councils working with Susan and Libby, I'm hoping that by the time we come back next month, we can maybe close some of the gaps that we've got, not in terms of the solutions, but in terms of the ways of working that will lead to some of the better solutions. Everybody happy with that? Yes.
I just wanted to mention that the next theme is women, and we are theming it around not fragile like a flower, fragile like a bomb. So we are hoping it's going to be quite hard-hitting in our women's health focus, given it's March is Women's International Day as well.
Okay, and just a bit of a plea from me. I've heard over the what feels like years now a lot about the women hubs, that kind of thing. And taking Martin's point, can you make sure that we get where it's not working quite so well too? This is something we're all passionate about. Yeah. Thank you. Okay. Well done, Lucy. Thank you very much, everyone. So let's move on. Chair's report. So that's me. So, colleagues, I want to start with a huge thank you. I want to thank all the executive teams and all our staff, actually, for their help and support through such a difficult period of time that we're going through. That's not just in the ICB, but generally across all our partners, not just in the NHS and elsewhere. But if I can just indulge in terms of reaching out to the ICB team, if you think about the changes that you're going through of scale, at a time when we've already been through a change process, not that long ago, and coming together and doing the planning, this is a big ask, and I just wanted to reach out and say thank you and recognise all of that. Because I reflected back on my own report, and I don't think I actually teased that out enough. So I thought I would say a few more words here. So getting into the detail of my report, since the report came out, I know it says in there that Steve is leaving us on the 31st, which is Saturday. So probably you're asking me what we're going to do next. So I'm just going to tease that out. So we will now be approaching an agency, a recruitment consultancy, to help us find an interim cluster chief executive. And alongside that, we'll be looking to get a substantive post for the cluster chief executive. So we'll be doing both on the basis that getting a substantive role, the individual is likely to at least have a long period of notice, let alone the recruitment time it takes. And we would really benefit now from actually having an interim in to help us on that process. So I thought you ought to be aware of that. In terms of organisational change, some of the things that will come up later on, but I think as we're in public, I ought to just share some of this, is that the delegations for post-consultation for what we call Tier 1 and Tier 2, which is the Board Director Executive Group and the tier below. That has now been led by an external person who's very knowledgeable in this space, that's helped us work with both the Cornwall and Isles of Scilly and Devon executive teams. And I lose track of time, I think it was Wednesday, the non-execs met and based on our formal delegations that we gave last month, decided the outcome for Tier 1 and Tier 2, and that will now be going through the communication process of all those impacted on that, and we will start the interview process as we go through February. So phase 1 is now in full swing, and we'll obviously start to look to move on to phase 2, which is all colleagues across the ICB, across both elements. So I thought that would be a helpful update. On the other points, I've written in here, there's nothing to change on Cornwall and Isles of Scilly. We're still in a position where we're looking for our 4th year of break even, and our planning for 26-27 is looking to break even as well. I think it is worth saying Devon is having a challenging time in 25-26, the current year, and equally a challenging time trying to get to a plan that we're happy with for 27-28, and for that matter, the 3-year plan. And that's why I'm teasing out in here, just for the public to be aware, is that we have a dedicated team working in Devon, led by Libby, with some external support that with our providers, and that's not just at chief executive level, that's at clinical level, most importantly, and finance level, but led by the teams. It's a collective piece of work signed up to by everybody in Devon, and principally will give us the capacity to support the teams actually come up with a plan that we can deliver and sign off as non-execs and as sovereign boards across the whole of Devon as we go through the end of the financial year. Anything you would like to add on that before I move on? No? Okay. I'm just going to make one other call out from here. I just want to say congratulations to Neil. I'm going to embarrass you in public. All right. Well done. I've worked with Neil since I first came down, which is 6.5 years ago. And I remember the first time I met you, Neil, thinking, gosh, this guy's going to make a change. And you have. So the recognition maybe come from somebody a little more senior than us here. But we would like to recognise everything you've done for us as well. So well done, Neil. All right. Okay. Okay. Has there been any questions on my report? No? Okay, so let's move on. We're going to go, first of all, to Susan as the Chief Executive Report.
So I think the plan was Libby and I were going to try and do this between us because there's a joint Chief Exec report.
Okay. All right. Okay.
That's the case. So I think
I'm having a nudge. Yes. I'm having a nudge from my colleague on my left, which is Libby. That's right. The ribs are hurting. So, Libby, go first.
Apologies, Chair, for not being clear on that before we started. So just to pull out a few key messages from my perspective. So as the Chair outlined in his report, Steve Moore will be leaving us from the end of this week. So just want to echo our best wishes and thanks to Steve and his leadership of the executive team in Devon. And obviously with myself and Susan continuing to cover the CEO arrangements across Devon and Cornwall and Isles of Scilly, we do have a number of interim execs in the room with us at the board, and just to extend our thanks to them in stepping up in a difficult time and covering the elements of both Susan and my substantive posts. So huge thank you to colleagues. Again, as the Chair stated, in terms of the ongoing staff consultation and restructuring, we as an executive are very cognisant of the impact of the ongoing uncertainty of these changes on all of our staff. And we have therefore a range of mechanisms to ensure that all our staff are continually briefed and supported through this time. And there are details of that within our paper. And again, a huge thanks to all our staff for their continued focus on the health of our population and the essential work that they're continuing to do throughout this difficult time. In terms of planning, just wanted to add in relation to commissioning intentions, which I know have been mentioned. From a Devon perspective, following the approval of the Devon Health and Care Strategy last year, the work to translate that through into our commissioning intentions has been significant to ensure that we prioritise the right areas to utilise our available funding. And we're currently translating these commissioning intentions through into delivery plans, as the Chair has referred to, through our plan over not just next year, but over the coming years to achieve sustainability and stability for our population in Devon. So I think at that point, Susan, I'll kindly hand over to yourself.
Thank you, Libby. So I will take the CEO report as read. However, I'd just like to point out a couple of things. We have included in the annexes the health and wellbeing report for Cornwall and the Isles of Scilly that will be going to the board. A really important piece of work that we've done. Not only is it the first time we've brought our commissioning intentions to a public board for 26-27, this is a 5-year plan, and what you will see in the annex is how we've addressed the whole life course. So we've talked this morning about children and young people. So it's all age groups. It's worth a read. As I said, we'll be taking it through our Health and Wellbeing Board, done very much in partnership with our local authorities, responding to the needs of our population. I think the other thing that I would just like to mention is we can't ignore Storm Goretti and the devastation that it's brought to both Devon and Cornwall. However, I'd like to take this opportunity to thank our system partners, particularly during Storm Goretti, where we had some really, really difficult conditions. We've seen most places our acute trust impacted, our community hospitals impacted, but a huge thank you to everybody, voluntary sector, local authority, who all came together to look after those who are most vulnerable and to recover relatively quickly when we're already in quite a difficult, pressured winter already. We've seen our acute trust and system partners declaring internal critical incidents, but again, we've turned those around very quickly. So our ability to come out of critical incidents, I'm seeing year on year improving. And I think that's testament to the services that we've commissioned, particularly within our community, about receiving patients much more quickly from the hospital, or in fact preventing them going in the first place. I'd also just like to mention, you've mentioned it already, Chair, about women's health. I'd like to publicly acknowledge Deb O'Niens, who received an award for the leadership that she provides for us in Cornwall and the Isles of Scilly in tackling long-standing health inequality in women's health particularly, and I know this is something she's sharing with colleagues in Devon, a really fantastic award, and we continue to work with Deborah, who's leading on our women's health strategy. I would just urge people to have a look at the appendices, which give a much fuller and richer view of what we're doing at the moment for our population across Cornwall and the Isles of Scilly, whilst also working much more closely with Devon and showing some of those good practices. That's all I'd like to say at this point, Chair. Thank you.
Okay, thank you. Any questions? No? Lopa?
It wasn't a question, Chair, if that's all right, but it was just to say that I really like this report. The joint report works very well, but there's a lot of good news in there, and I think that's really important to acknowledge, and particularly for me, bullet point 57 about lung cancer screening programme. I think that's tremendous. And item 69, we know we have the Health Innovation Network as well to lean on. And item 59, well done to the Devon CMO for becoming a radio star and explaining how, healthcare works. So just wanted to pull those out. Thank you.
Very good. Thank you very much. Okay, so let's move on, colleagues. So we're going to move into the session of asking the non-execs, the partner members and the participants. Oh, hang on a second before I went too quickly. Is that a hand up in Cornwall, or is that...
Yes, please. John, it was just to say that the report that's going to the Health and Wellbeing Board with the life course approaches is so we can get a statement to go into our strategy that there's a view that it aligns with the health and wellbeing strategy, and we've worked with Union's team to ensure that we are in a good position to assure the Health and Wellbeing Board in that respect. It is a subset of the 5-year strategy that will be coming to the board on the 10th. So if anyone's got any feedback on that, please let me know as quickly as you can, and we can ensure that's reflected in the strategy.
Thank you. And I'd like to reach out to Cornwall Council and thank them for accommodating us in terms of some extra time to do this formally through that unit. So if you could pass on our thanks, that'd be great. Okay, so we're going to go through non-execs first. Anyone who wants to say anything, and then we're going to start with partner members and then the participants who want to say anything as we go through here. So we'll start with Town. Anything you'd like to say?
Yeah, just to add that we haven't got a written report from the People, Customer Experience and Equity Committee.
Right.
But I have got a statement from our two people leads. So the Devon system position remains adverse to plan at month 8, with workforce numbers and pay spend above agreed levels. There are early signs of stabilisation in parts of the system, with some trusts now closer to plan following CIP and Mars actions. However, this is offset by a significantly adverse position at RDUH, which remains the primary driver of the overall variance. It's not the only driver, though. Sustained focus and robust system grip will be required to hold system outturn position and support recovery for the remainder of the year. Planning for the next year must be accompanied by detailed plans on how workforce reductions will be achieved, with clearer route for funding cost of change. Cornwall and Isles of Scilly system, month 8 data showed RCHT on plan and CFT forecast outturn for year above levels originally set out in plan. So at committee, we were assured on the accuracy of the reported positions, but less assured about the trajectory and outturn for position given the impacts of winter pressures in Q4, and continued concerns that financial measures to ensure break-even mask the underlying workforce position, which will have a knock-on impact to the starting position for 26-27 plans. At the next Workforce Committee, we will be looking in more detail at the plans for 26-27, and we will be being forensic in our investigations about the CIP plans, folks. I'm just putting you on alert around that. We have to have clear plans that are evidenced in detail behind them. Thank you.
Thank you. I think if we just reflect before I move on, we started as a cluster on the 1st of September, and I think we got to about the 16th of September when we commissioned a review by Pricewaterhouse that looked into our grip and control and planning for Devon, I have to say. And one of the things that we, as a lesson and learning for that, is that we must make sure that we have plans that have assurance in them, Tom. And I think what you're asking for is sufficient level of detail that not only are the sovereign boards, provider boards, gaining assurance as they should do, but actually that we just don't tick the box. All right, we have to have enough detail going through your committee, and more specifically Graham, but also for Cornwall through Martin's committees, to make sure there's enough granularity on there that we can take assurance. We have to be in a position of giving assurance, but it can't be false assurance. And we can't keep moving on to a position of it's high risk. These need to be plans that we truly believe that we can deliver. Fair comment?
Concur.
Very good. So in which case I'm going to go this way around. Graham.
Thank you very much. So the FPQ committee focuses on the in-year, and I'm going to talk obviously about the Devon part of that. I'd just like to reflect first upon the entry point into this year, because I think it's important we all reflect upon the position we were in to then comment on where we are. We entered the year knowing that our performance was mixed and areas that we need to improve. We also entered the year knowing that we had a financial challenge from the exit from the prior year. And we know that the funding formula that is applied nationally to each ICB, Devon has been receiving above its fair share. And the intention is to reduce that to the funding formula fair share over a period of time. To enable us to do that, we have been recipients of what's called deficit support funding. And there are some conditions attached to that funding being provided to us. We also entered the year knowing that we had to have productivity gains in NHS parlance, continuous improvement programmes, SIPs, to deliver efficiencies. And we knew that as we entered the year, the maturity of some of those plans was low, and yet had to deliver in year to achieve the financial position. We are now heading towards the end of the year, and therefore, whilst we are by no means, as it were, giving up on the in-year, because the exit point is going to be really important, I think we are seeing a reasonable forecast of where we are going to land. And in some subsequent papers, you will see that we are financially now off plan. I've already alluded to some of the challenges within it, but as we have moved off the deficit support funding that we received in quarters 1 and 2, has not been received in quarters 3 and 4, and that those backloaded SIP plans have proved to be ambitious. We have therefore landing in a position where, amongst other things, the balance of our recurring versus non-recurring SIP delivery is more weighted towards the non-recurring, which means that the recurring piece that should have been achieved means that the run rate is going to be higher at year end than we would have anticipated. And that does have some consequences, and you see it in the workforce numbers that Dan has already touched upon. That said, we have seen changes in our performance over the year to date. Some of these are, however, proving very intractable. But I do highlight that some of the areas of successes that the committee has recently looked at are things, for example, like vaccine levels are extremely high in Devon. We looked at AMR recently, and that's in a very good position. We looked at the winter plan, and whilst we are now into floods rather than winter, we had an early flu, and of course it's never perfect. But I think we have demonstrated a good performance in the circumstances over winter. So I'd just like to highlight that there are some real pluses through to this year-to-date position. I'd also like to highlight that as we move forward, we see it as extremely important that the clinical piece is first and foremost in our minds. And some of the work that Penny's been leading in terms of making sure we have an adequacy of an EQIA process is really, really important, because as we move forward, we do need to make sure that we have in mind that whole triangulation piece of clinical outcome, performance, workforce, and the money. So enabling that to happen is really critical. Let me just touch upon 4 areas for our last meeting. There are no minutes yet because it was only held recently on the 15th of January. But just to inform people on this, in terms of the ICB finance position, that is what we call NHS Devon, it's the ICB. We have been in a position and continue to be in a position of satisfactory assurance on 3 domains: the performance itself, the savings and the risks. I would, however, just say that the mixture of our spend is slightly different from the plan, but overall we are satisfied of our delivery of our financial position as an ICB. In terms of the position for the system as a whole, what we call One Devon, we have not been in a position of assurance for some time, and that is really reflecting against the original plan. And as we can see the year has unfolded, we have tracked off plan, and colleagues will be picking that up a bit later, around month 8, month 9, and a process of changing the forecast. So the fact that we have no assurance in any of the domains, I think is relatively self-evident. Although I know it might sound controversial, but the no assurance is around financial performance, efficiency savings, financial risk and workforce. I would, however, like to move to a more positive area of assurance. We looked at safeguarding. It is a statutory responsibility of the ICB, and at the last meeting we looked at the objectives for the ICB, the plans of the things it intended to do and its achievement of those. And I'm pleased to report on that one we provide assurance, satisfactory assurance. And then the last area I'd just like to touch upon is the ICB's plan delivery that has 6 key objectives in it. It has not changed over the last couple of months, but there are 2 areas that the ICB has tracked off, and they are important areas, and we know why they've tracked off, but I should at least report those to you. One is around clinical service transformation and delivery, and the other one is on workforce and infrastructure. And this plays into a lot of the things that we would need to talk about in terms of the clustering arrangements, the uncertainties of workforce, etc., etc. But we are off plan from an ICB perspective on those 2 domains. So I want to end on a high. We are seeing lots of good things. I just feel it's probably up to me to highlight some of the more difficult ones, but please do put it in the context of some really good performances all round. Thank you.
Thank you very much. Martin?
Thanks, John. Again, no written report meeting last week or the week before. So just a couple of things I'll pick out. We reviewed the Cornwall Council ICB Section 75, Section 117 joint contract, which is going to also come to the board, but committee, we're happy to recommend that to the board when it comes. We had a couple of escalations, deep dive on stroke performance in Cornwall. Noted some improvements in some slightly previously lacking results. So good news there, but probably remains a slightly fragile service that we will keep an eye on. We had a review, a sort of high-level review of perinatal safety in light of the various national initiatives looking at maternity and women and children's health. Again, a couple of recommendations, but broadly satisfactory high-level report. Money, as you suggested, John, broadly on track for the year to date and projected for this year to be on track. Partway through the sort of process for next year's contracting, small gap remaining, but some optimism that should be closed by the time we get to the sort of sign-off end of that spectrum.
All right. Thank you. Neil.
Thank you, Chair. I'll take most of my report as read. There were 7 important points that the committee wished to raise from the last meeting, but I need to add 2 key small words to item 5, and I'd like to just make sure that comes across. Item 5 says the ICBs are required to provide strategic commissioning, and the committee have advised that care is needed in terms of commissioning for neighbourhoods. I'd like to add in the words with and for neighbourhoods. The committee felt any such approach should be informed in terms of potential delivery from a wide range of partner, and we go on to mention that being VCSE, primary care, and the experience of people living in communities and the neighbourhoods served. This is absolutely vital, and I can't wish to get that point across. If we do 2 neighbourhoods, things won't happen.
Yep.
I'm going to leave it at that. That's just a message I really need, I'm afraid, to put across, and that was felt by the committee in terms of the way we develop working around neighbourhoods. It has to be partnership, collaborative, and activating our workforce towards a common purpose.
Very good. Thank you. I assumed, but I will ask, there's nothing, I don't think you've had a meeting. Oh, yeah, I do apologise. Over to you. My mistake. I thought you didn't have a report, so do go for it.
No, it was, in fact, we had our first meeting in common on the 1st of December, right, which is sort of fading into distant memory. But I just wanted to comment on a couple of things. Firstly, it was the first meeting in common, so I wanted to record my thanks to both sets of executives and auditors from all sides. And I think the meeting went well. We covered quite a few things. We specifically covered in audit and risk the things you would expect: counter fraud, losses and special payments, and EPPR. And there were a few things. Risks across the system are rising. I think that will not be a surprise to anybody because of the considerable amount of change. And then there were a few specifics that we had raised. The system has taken up the integrated single financial environment, and that has not gone as smoothly. I'm looking for Simon. Not as gone as smoothly as possible, but colleagues are working very hard to work with that new finance system. We also discussed procurement and contracting, and there are some implications in terms of capacity following CSU support being withdrawn, perhaps. And finally, there was the issue around the governance review, highlighting a varying understanding of risk assurance categorisations across the system and the mitigating actions for those. And I know that's very much under the governance review that Philippa mentioned earlier. Okay. So those were the 3 things.
Thank you, Raj. Thank you. I don't think there's anything from yourself, Salma, is there? No, that's fine. Thank you. Thank you. That's why I thought I'd come to you last. Okay, thank you, non-exec. So now we're going to move on to the partner members, first of all. So we're going to do Devon first, so Frank.
Thank you, Chair. I'll take the report as read. The one thing I would say is it's not written by me. It was written by the various constituents of primary care. So that's medicine as in general practice, pharmacy, optometry and dentistry. One bit I would like to highlight from what they put in was the pharmacy issue. I think we should do a deep dive into the whole process. We have had a national pharmacy that had 12 pharmacies in Devon, and the regulatory framework, if I'm honest, is relatively toothless. So they have gone into receivership, and there were signs of this about a year ago. So we probably ought to look into that and feed it up nationally, because pharmacies may well have significant issues in the future. On a much more positive note, the MPOD committee, I asked at the December meeting whether we could have permission to try and create a Devon Primary Care Collaborative. We were told we didn't need permission, get on and do it, and link with the executive, and they have got on and done it. So they are in the process, and this is 610 different organisations, the process of creating Devon Primary Care Board. To give you some idea of the importance of that, that's £690 million of the spend in Devon. So this has to be an organisation that has a voice at the top table within the ICB. And I mentioned that specifically about the 12-week turnaround programme. There are plans to try and get some of them in there, but although this organisation doesn't exist yet, I would suggest that the chair and vice chair ought to be approached. They have put in a paper
to do what?
To be involved in the turnaround programme, because in terms of the voice of primary care is going to be really quite important to it. 690 million budget, and integrated neighbourhood teams are the future, a delivery model. So it's just a request. I know that there's a lot of discussion going on about the who can and it should be, but that organisation doesn't quite exist yet, but it will exist.
We'll pick that up later for sure.
Okay. So they are making progress at pace. The underneath that are going to be 4 pillars of the local medical pharmacy, optometry and dentistry committee and the VCSE. So it's a 5th pillar under there, and there would be ambitions ultimately for some community, a 6th pillar and community. But the GP collaborative is also coming together, and there will be another meeting in March of just general practice, and hopefully we will create a CIC fairly soon after that. The other positive thing is there is huge enthusiasm about INTs in primary care. There's lots of ideas. They do want to be involved. A bit of honest feedback is they are not quite sure how they can get involved at the moment because of the changes, but I fully understand why that has been so difficult, and that we will engage with them going forward. So just...
Okay.
Yeah.
Very good.
Okay.
Well, I hope they are engaged, because you've got earmarked money for this for next year, so we need to align that conversation pretty quickly. Okay, thank you. Lincoln.
Yes. Yeah, we wanted to highlight the health protection role of local authorities. Our health and wellbeing boards have looked at the collaborative report. There's a Peninsula committee which looks across from a local authority perspective at all aspects. We wanted to particularly highlight community infection control and prevention. And this is something we've raised certainly in the Devon system with the Chief Medical Officer. Penny, we picked that up with the system quality group. But just for the board's awareness of the importance of ensuring that in the new structures, infection control and prevention remains prominent, and particularly community aspect. I wanted to pull out as well healthcare-associated infections, that we've been seeing some of the signal infections increasing. That's something we need to look at collectively. And our good old friend TB remains a challenge. It's one of those things when you have a complex multi-drug resistant TB case, it can be really expensive and really challenging to manage. So it's one of the reasons why that core embedded community infection control and prevention is so important. Thanks.
Thank you very much. Let's go to Anne-Marie next, please.
You've got a hand up, John, I think off of Lincoln's.
I saw that. I was going to come to you in a second.
Yeah, that's fine.
Yeah,
no
thank
problem.
you. Yeah.
All right, and colleagues, apologies to the board that you don't have a written paper. The requirement came at a time when we were having our Ofsted ILACS inspection, so for children's social care. So, colleagues, it's important to share with you the latest in terms of local government reorganisation. Clearly, that's only affecting Devon, not Cornwall. We are expecting government to start consultation on that early next month with decisions on LGR by summer recess, so by middle of July. There are a range of options for government to pick from that will then be implemented by April 2028. So a period of significant change, undoubtedly, across Devon in respect of the outcome of that. At this time also, it's the time of local authority budget setting. Clearly budget setting on an annual basis, but within the context of the fair funding review outcome and the 3-year settlement that was announced just before Christmas. That will be impacting the local authorities differently, but to give you an example, so for Torbay, if government confirm on the 9th of February that which they have indicated through their consultation, that would mean a 13% reduction in Torbay's funding across 27, 28, 28, 29. So that's of our entire net budget, a circa 13% reduction. So clearly that working together and how we do that across the system will be more and more important. I think it's also useful, obviously we've touched upon the SEND challenges earlier within the meeting. Important to balance that in terms of actually some of the inspection on adult social care. So it's a new framework of inspection that is being rolled out across the country. Torbay and Plymouth have had their inspections and outcomes published, both of which were good. Devon County have been inspected, but their outcome has yet to be published. But Chair, hopefully that's a brief overview for partners.
Thank you very much. Sam.
Thanks, Chair. I think it may have been Steve first, but I'm happy to start.
Yeah, you can.
Okay. Yeah. So I'm reporting on behalf of NHS Trust and Devon. As an acute trust, I just wanted to start by saying thank you to staff over the last couple of weeks. It's obviously the most challenged time in the NHS, and I'm very conscious how hard people have been working. That comes off the back of a period of industrial action by resident doctors between the 17th and the 22nd of December. So we've had a real period of challenge nationally. Locally, we've had a few interesting events in the last couple of weeks on top of that as well. So obviously there was the bomb incidents both in Exmouth and in Plymouth, which colleagues have had to respond to and as ever have pulled out all the stops. And then locally in East Devon, we've had the impact of particularly of Storm Chandra in the last few days, where we've had issues around managing flooding and impacts on staff and being able to get to work. So that has meant that the last few weeks have definitely been a challenge. In terms of just picking up some specific points, despite all of that, we continue to make progress on our elective waiting lists. And so that is really good in terms of the progress we're making both on the long waiters and the overall position. We still have challenges in terms of the amount of demand coming into the system, and that is something we need to pick up because the overall waiting list size, we could have made more progress if we hadn't seen that elective demand growth. We've got conversations going on both with Devon County Council and with Anne-Marie and colleagues around the future of social care arrangements. We have not made the progress we planned for in our plan in terms of no criteria to reside with Devon County Council for the year, but we're working really constructively with Penny's chairing between the ICB, the IDUH and Devon County Council to see what mitigation plans can we put in place, and we are beginning to see some improvement. And then there is obviously a conversation going on between Torbay and South Devon Trust and Anne-Marie and colleagues at Torbay Council about the future of social care arrangements there.
Okay.
I just also wanted to say, just to pick up on the finance position, it's important to say both Torbay and Plymouth remain on track with their financial plan for the year. It is the RDUH who is off plan and declared a £44 million movement at the beginning of January. So we remain on track to deliver that revised plan. The other two trusts are on track to deliver their plans for the year. And then finally, just to pick up that we are continuing to work on our One Devon EPR work. Important for the board here to note that Torbay and South Devon go live on that in Easter. So there is a lot of work going on in the next few weeks to extend the EPIC instance, and then that will be followed by UHP in the summer.
Very good. Thank you. Phil?
That's all right. Thank you. I'm providing a report on behalf of mental health services in Devon. Last public meeting, I provided a report around dementia care, and then the intention is to come back to the next meeting with the draft dementia strategy for ratification, so some continuity from last time. This time, what I'm offering the board is some insight around some of the key performance target delivery across both Live Well, South West and Devon Partnership Trust, that are the two main providers. These are a fairly narrow range of measures, but they are the national ones. The areas that have been highlighted as concern, which I will just focus on, are the number of what we refer to as inappropriately placed out of area placements. This refers specifically to people who need psychiatric care in an inpatient setting, more of an acute nature rather than long-term care. That is defined differently. The inappropriateness is defined as being there is clinically no reason why the patient shouldn't be placed within the home county effectively. So there will be a larger number of patients out of area, but appropriately so, because maybe they have a specific need that our units aren't able to provide. The measurement in the report refers to the number of patients at the end of the calendar month that were inappropriately out of area, and that is a higher number than it has been previously. I think 12 is the number if we look at the report. That is in part a representation of the demand pressure in the system. It is also in part a representation of some of the blocks that we have in the wider care system around discharges onto appropriate accommodation, some providers feeling not able to support people with discharge plans, so they are therefore delayed discharges on some of our wards. But report as read, and the main issue that I'm highlighting is inappropriate out of area placements.
Thank you. Any other colleague around the table from Devon who would like to add any words? Yes, Diana. Yeah. 1 in 2 work. We're 50% cut on electricity. No?
Right, now I'm working.
Lincoln, can you switch yours off, please? Thank you. Yeah.
Yes, it's working now. Thank you.
Thank you.
I didn't submit a paper as I didn't have anything specific I wanted to report to the public part of the board, but I do want to record my thanks to all executive colleagues and other board members who, since I took up this fairly new post on behalf of the Devon VCSE Assembly, have been incredibly encouraging and supportive. I particularly, if I may, just wanted to respond to a couple of the comments that have been made during the conversation today. Libby, in terms of the thinking around the executive committees, to consider how the VCSE in Devon, similarly to how I understand it happens in Cornwall, might be engaged in those conversations, because it's very much about being part of the conversations at the beginning and at the very top level of discussion. Secondly, Anne-Marie, in terms of the issue you raised about the local government review, I think the feedback I'm receiving from lots of community colleagues, VCSE organisations, is around the real need, and I know everybody is doing this, but I just wanted it recorded, to think about how we might, when the decisions are starting to be made around the local government review, think about how that fits with the NHS approach to, for example, neighbourhoods, because there's a lot of confusion and a lot of difficulties, I think, with some of the same names and the same words being used for very different things. So I just think it would be really helpful for us to all think about that. And also, feedback I'm receiving is it would be a real shame if we didn't manage this time around to think more system-wide about how the NHS and the local government review system ends up working together rather than separately. And I think my third point, if I may, is just to add my support on behalf of the VCSE sector to Frank's comments about the Devon Primary Care Collaborative. We've been engaged very effectively and very helpfully in all the conversations and really look forward to the new organisation being set up.
Okay. Anybody else? Thank you. Right, let's move on to Cornwall and the Isles of Scilly. So before I bring in Steve, I just want to say thank you for everything you've done for us. You're still with us for a short window of time, so our loss is Morecambe Bay's gain, I guess. But I just wanted to say what a fantastic contribution you've made to Cornwall and the Isles of Scilly generally, and particularly to your own organisation and to our board here. Yeah. So you will be missed. Thank you ever so much.
That's very kind, John. It's been a pleasure and a privilege to have the role in Royal Cornwall Hospitals, but also on the ICB board as well. And I've certainly been incredibly fortunate to work with passionate colleagues across our system wanting to do the very best for Cornwall and the Isles of Scilly. So I'm excited about the new role and sad to leave Cornwall and the Isles of Scilly as well.
Thank you. All the best to you and your family. So wearing your day job now hat in terms of our board, over to you. Anything you would like to share?
Yeah, well, 4 things. I'll take the report as read. Happy to pick up any questions if colleagues have them. But the 4 things I'd like to cover. Firstly, I'd like to echo Susan's comment about Storm Goretti. I know we all know this, but that was an exceptional event, upgraded to a red weather warning, which is very, very unusual. It had huge impact across Cornwall and the Isles of Scilly. Tens of thousands of houses without power, or in some instances without water. Huge disruption across the county, which left multiple impacts on health and care provision and services. So I just wanted to say thank you to the entire system, Cornwall Council, CFT, RCHT, SWAST, primary care, voluntary sector, but actually much more broadly than that, the police response to fire and emergency response utilities was fantastic. Colleagues worked incredibly hard in very, very challenging circumstances over that 24-hour period. So first thing I want to do is to thank everybody who played a role in responding to Storm Goretti. The second thing is to just recognise the extraordinary efforts. Apologies, I've got a bit of feedback, colleagues. I think it's from in the room. I'll keep trying, but if colleagues could turn their mics off. Second thing was across the whole system, all partners remain focused on improving urgent emergency care. We have seen periods of exceptional pressure. SWAST, our ambulance service, have been operating at Route 4, their highest level of escalation for much of the period since the previous ICB cluster board. RCHT and CFT operating at periods of Route 4. Similarly, from a University Hospitals Plymouth perspective, and Royal Cornwall Hospitals has had brief periods in extreme escalation internally at brief periods of critical incidents. Despite those levels of operational pressure, we are continuing to see improvements in urgent and emergency care. So particularly seeing year-on-year improvements in ambulance handover performance, which is directly translated into improved Category 1 and Category 2 response times. So thank you to everybody who's been involved in that. Both NHS provider trusts in Cornwall and the Isles of Scilly Cornwall Partnerships Trust and Royal Cornwall Hospitals have been working incredibly hard around financial delivery. So both the trusts and the system continue to forecast a financial balance for this year. That's been really very, very difficult for the system, and it's required some very challenging decisions to be made. So I'd like to say thank you to all colleagues who've been involved across both trusts, particularly in enabling that position at this point in the year. And clearly we need to keep a focus on that over the last 2 months of the year. And then the final thing to update on from the provider trust's perspective is we've been able to make some progress on reducing the deficit for next year's plan that was in our first draft submission, and that deficit all sat within Royal Cornwall Hospital. So that's improved to an extent at this point, and we've identified the number of steps and actions which would enable potentially a route towards a break-even position for next year. That requires absolute focus over the period between now and the final plan submission on the 12th of February, and all partners are working really hard towards that, John.
Thank you very much. Debbie.
Thank you, John. I'll take my report as read and just pick out a couple of points by way of updates. So as the report highlights, we've had a huge focus on out-of-area placements, and I'm delighted to report that for 1 week in January, so it's not sustained, but we're holding a improved position, but for 1 week in January, we had 0 inappropriate out-of-area placements for Cornwall and the Isles of Scilly. So that's been the result of huge amount of joint working and also some investment that was made by the Integrated Care Board last year into the VCSE chaos run facility, the Nest, and that has made a difference to us all. We still have limited resilience, so therefore it is a challenge to sign up to sustaining that at the moment, because we do benchmark low overall for beds per 100,000 population. That said, this isn't a request for more beds. It's actually a renewed focus on community alternatives to beds so that we can provide care much closer to people's homes. I also wanted to highlight, because I don't think I've mentioned this to the board before, but I'm also the Chief Executive Lead for the South West region for the Mental Health Learning Improvement Network. And we were delighted that in addition to the elective Learning Improvement Network and the non-elective Learning Improvement Network, nationally there was a recognition that parity was required for mental health. And I'm pleased to say that our South West region network is up and running and active, and is focusing on the challenge set to us, which is to reduce overall length of stay for adults and older adults. It's a mixed picture, Chair, however, with success in this regard, because as a system, we were 5th out of 7 systems in April when we started the work on length of stay. But unfortunately, we've now dropped to being 7th out of 7 as a South West region. However, it's not all bad news, because we have seen movement in some long stay patients. And so our length of stay is always calculated based on length of stay at discharge. But I am delighted to say that Devon and Cornwall both have projects that are focusing on length of stay, and they are both within the South West region reporting improvements and gains. But focusing on inequalities, colleagues, those with dementia, those with complex emotional needs, and those with autism stay longer. And so we will be looking as a regional group, but also then within the ICB, working with the local authority and the ICBs to how we can address those inequalities so that we can ensure that those groups aren't staying longer than those without those conditions. Thank you, Chair.
Thank you. And Una, before I bring you in, can I just say to everyone, the reason why Ali Bullman isn't here is that Ali's been off ill for a while, and she's having a staged return to work. So do pass on our best wishes to Ali. I bumped into her in New County Hall the other day, so it was good to see her. So I don't know whether you want to cover anything off there or your own observations, Ewan, but please pick up the sort of the wider dynamic for us from your seat, please.
Thank you, and I will pass on that message to Ali. I think a couple of things just to reflect people are saying about Storm Goretti. We've also seen from that Storm Chandra and Storm Ingrid, and I think you have to factor in climate change and the effects it's having. So there's real pressures on our systems, and we have to think about in the future. Apart from all the other challenges we have, is actually the resilience of our systems with the extreme weather events, not just in winter, but also in summer with heat and that as well, which is a bit of a concern. Going to the report, a couple of things have changed. So the consultation on the budget, I think, is closed now. And so the council are actually finalising looking at that budget to be taking it to full council in the end of February as well. So things have moved on a bit there as well. From the next item 5 about CQC, a draft report has been received and the team are looking through that for factual accuracy, and that's ongoing at the minute. But as we know in Alza Scilly, they published a good rating. We would be anticipating similar as well. So that's moved on since the submission of this report as well. And then the other items that are there are as read. Within the public health domain, as I say, we have launched a £500,000 prevention fund, which is working across the council with other teams. That has been, process has been concluded, and we're working with teams to mobilise those things for next year. Our Ageing Well survey, we're working through that. There were, I think, about 3,500 responses, really high level of response. Actually shows the public in Cornwall are really interested in sharing their views on productive, healthy ageing, and actually how we can work with our communities to support moving into our elder years in better health and reducing our the healthy life expectancy, of improving on that and reducing people living with longer term conditions and multimorbidities as they get older, which is in everybody's interest. And I would like to then also just echo when my hand was raised with when Lincoln was talking about it. There are genuine concerns about the resources and resilience in infection control and protection into the future. We're very positive to want to work across the system with other organisations on that, but I would make a plea to make sure that it's something that is actually taken and moved forward as we cluster, that it doesn't get lost in the future in plans, that we need to have those systems in place. We've done an awful lot of good work in the past, and it would be a shame to lose that. So it is a word of caution to echo, as I say, all the directors of public health across the Peninsula are unified in feeling that we need to have serious conversations about that. Other we will see the rise of infections that we've worked so hard to address in the past. So that's really the main issues related to the report, if there's any questions.
Thank you, Ewan. And if when we get to the discussion later on this afternoon, will you bring that point up again?
Happy to.
Under the organisational change question, that would be great. Okay. Now, unfortunately, Smitesh has had a close family bereavement, so he's not here today. So I'm going to move on to just ask Stuart, is there anything you want to add?
Smitesh has asked me to just sort of talk through the public care paper. I'm happy to do that briefly, and obviously thoughts with Smitesh and his families. So, like other colleagues, I'd like to just sort of commend the response of general practice to Storm Goretti, where we had 21 of our GP sites without power across the county, but despite this, all surgeries are able to continue service, and largely that's due to our spirit of collaboration across our INTs, but also the support and infrastructure from Kerno Health that we're so lucky to have in Cornwall to find IT solutions to remotely handle calls from patients, and and again, thanks to other system partners for what was really an impressive effort to keep services going. slightly less optimistic note in the report, you'll see ongoing risk really to general practice, and therefore system with the BMA dispute with the government over the general practice contract. Whilst I think, how does that play out for us? Well, obviously there's the threat of potential move back to collective action again, which I think we handled fairly moderately in Cornwall, but also, on one hand, we've got a really good spirit of cooperation and engagement with INTs at the moment, whereas there are noises from the GPC to try and disengage with that. We're obviously, as a GP collaborative, advising against that, and we'll continue to do so. Also, of note, I think in paragraph 14, you'll see a figure there of 135% of general practice operating at 135% of capacity. I just want to clarify where that number's come from. That is from Kerno Health, our out-of-hours provider, saying that the numbers of patients that they're dealing with are 135%. Of what they're commissioned to do, and where it's always hard to get absolute data across the spectrum of general practice. It felt at our collaborative board meeting that figure was about right in terms of the capacity and demand in general practice. So just onto our primary care partner organisations. I certainly welcome the plan to support toothbrushing education in our deprived neighbourhoods. That's certainly something that in my own clinical practice is borne out all too often. And onto our pharmacists, just vital to recognise the role that pharmacies are playing in supporting our whole system. So 40% of flu vaccinations given to our population in Cornwall this year by our pharmacy colleagues, widespread use of Pharmacy First supporting us all in our system, and certainly in my day-to-day practice on calls, the access to Pharmacy First is not only very welcome by patients, but certainly by primary care as well. On the other side, just so important to recognise, like in the context of the support they're giving our system, that 60% of our rural pharmacies are reporting operating at perilous financial margins. Again, just with our opticians, I really like to recognise the MCES in Cornwall, where with opticians having read-only access to RCHT ophthalmology notes, and the way that can just improve the flow of patients through the system, and again is just highlights, if ever it was needed, the value of integrated IT across organisations. The last thing I just want to pick up on is a point that's been raised by Neil as well, which I think is just so important, and there's an example of this in the sort of end of life pathway design. The success, in my view, of the INT development thus far in Cornwall has become largely because of general practice leadership and engagement, and also our dynamic VCSE working together, coming up with quick solutions. And just to reiterate Neil's point that it's just absolutely essential that our GPs, VCSE and our populations are engaged in and continue to engage in the INT development as we move forward. So thanks everybody.
Thank you, and that's recognised by everybody. Stuart, I would also just like to rehearse again the fact that even on the call with some of our regional colleagues yesterday, we were trying to celebrate the fact that Cornwall Nails City is in the vanguard at the front of the national drive of what's happening here, and people are looking to us as to what next, and that's all primarily driven by a lot of the things that are taking place that Neil talked earlier on about. Collaboration at a local level has been inherently general practice rooted, and we lose that at our peril. And I think as we go forward, anything that actually is scaling up what we do must be able to go down that route. The one challenge I would just ask you to consider is general practice ready for that scaling up? Don't answer it now, but if of the scale of the left shift that we would hope to have, The ambition is one thing. If we then turn the tap on, we just need to be sure we can actually do that. So if you could just have a little think about how you work across with colleagues in the ICB to ensure that the scaling up exercise, because we're committing huge sums of money over the next 2 years into this space. We don't want to commit it and it not happen, and we want to happen and evidence it, because then we want to actually keep on scaling it. Thank you, Stuart. Emma, is there anything you'd like to add?
Nothing from a sector perspective, other than to say this is the time of year, as many of you will be aware, where we are in final quarter anxiety and concern about organisations' ability to continue to deliver into new financial year. I think that's twofold. One, just as a general point, we are seeing some significant financial precarity across the sector in charities who have a 20, 30-year history. So that's a kind of general picture of what's happening out there, and that's commensurate with the national picture that we're seeing. But it also links to, you know, our ongoing challenge around public sector contracts and our timeliness around confirming those contracts for sector colleagues. So just another encouragement to make sure, as we're working more collaboratively together over the future, that we start to pull back that planning and commitment timeline to an appropriate time where colleagues can plan for the new financial year. But more broadly, I just wanted to pick up on a really exciting note that was in Debbie's report, which she didn't mention, and I think it's something to celebrate at the start of, which is the whole system commitment to look at the development of a mental health strategy for Cornwall and the Isles of Scilly. We had a really exciting cross-sector conversation yesterday about the opportunities afforded by that. And it's something that all of us are incredibly excited that we can take a completely different approach to developing that strategy this year. And Ewan and I were in a part of that call, along with Colin, the CMO. So there are some really exciting opportunities, I think, to completely reshape some of those thematic issues that face our people and communities. And it's great to see that that is being delivered, or the ambition is to deliver that all age and across the entire system, and all the partners, including VCSE and general practice, being involved in driving that forward. So thank you, Debbie, for that.
Well said, Emma. I think I've covered everybody else off. Is anybody feeling that I've missed them, for which I apologise in advance? No? Okay, I hope you all feel that was an important and valuable update from across the entire system. Lopa.
Sorry, I just wanted to, not the good news bunny, but I wanted to commend two things, if I may.
Yes.
So in Steve's report, particularly around primary care, I don't know if colleagues have clocked it, but points 8 and 9, talking about digital implementation and the fact that in practices, 50% of access is online. I mean, that is quite significant. And secondly, on point 9, where he's talking about digital workflows now reaching stabilisation, I think that's all very fantastic news for productivity. And I know we haven't discussed productivity as a measure, but I just wanted to commend that, and also the openness and transparency in reporting. And then the other commendation is really for Phil's report on mental health. Phil, I really thank you for putting in the risks in your report and also the mitigations. I really would encourage, as Chair of Audit and Risk colleagues, can we try and do that for a lot of reports, because it really is valuable to understand your thinking when you're writing the reports, what the risks are and how they're being addressed. So thank you.
Never apologise about celebrating the good stuff, Lopa. Yes. Thank you. Frank?
There was just one thing in the local authority report from Cornwall which I think could be an absolute game changer, and this is from personal experience. My father-in-law on Saturday is going to come and live with us. He has dementia. He's been living in a nursing home for the last 18 months. Now, we're lucky enough to have a house that we can accommodate that with an inner section with a carer. The cost of a carer at home is just over 50% of being in a nursing home. So the discharge into their own home with 24-hour carers could massively change the cost of how we deliver care for people who are being discharged from hospital but need some help. So it in that paper, but I think it's a really important trial. And it's where they want to be.
Ash, would you like to comment?
Yeah, the evidence is that that care at home, particularly for those with the delirium, is proven very helpful, with a lot of evidence suggesting that with patients who are particularly in hospital who have a delirium, when we send them home with a 24/7 package or 24/7 carer, the reduction in delirium is significantly improved compared to that person remaining in hospital or moving them in temporarily into a nursing home placement. So I think it's 5 placements a week now, and you can hopefully confirm that we are supporting as part of our D2A work with that will be evaluated afterwards. But it was a piece of work that we had rolled out across Worcestershire and Herefordshire whenever I was placed up there, with excellent outcomes. So I'm really looking forward to the evaluation of that service. And again, as you've rightly said, if this is something that's proven, then I think it's a really helpful way of us to think outside the box moving forward. Just to say as well, Cornwall and the Isles of Scilly, we have a working group to pick up any of the dementia work, and that was one of the outcomes that our colleagues had put forward, that they wanted to be able to advocate on behalf of their patients.
I'll come back to dementia in a second, but Ewan, you want to add something?
Yeah, just to say thank you for that positive comments about that pilot. I was trying to be brief and keep it as read, but I didn't go into it. I think one of the benefits of us clustering is I'm sure we're very happy to actually, when the evaluation has been concluded, is work with colleagues in Devon and feel free to reach out to colleagues in our patch as well to look at how it's going even at this stage, so that, you know, this is one of the benefits of merging, that we get to talk and share our experiences.
Very good. Libby, can you comment on how we're going to pick that up? Also, who else? Yeah, Penny. Sorry, Penny probably better. Sorry, yes.
Yeah. So I think it's really key, actually, and I was just making eye contact with Aisling to say let's connect up with Kerno. I really like that persuasive metric, which is all around, you know, the whole QUIP philosophy, Chair, which is that you both improve quality but you also remove unnecessary costs. I'd like to think, Sam, we might be able to feature an initial conversation in our No Criteria to Reside strategic group with Tandra in the first instance, and I'll engage with Phil. But we would need to take your learning promptly. Thank you.
Do you want to say that? Sam, and then Libby.
Well, just to link to Penny's comment and also Frank's point, we need to fundamentally redesign the P1 and the P2 pathways and our intermediate bed model. It's a 20th century model, and it's costing us an awful lot of money. And I know there's work going on at the ICB to develop a case for change, which I'm really supportive of. But it's a really important conversation, both for NHS partners and local authority partners.
I hope somebody picks it up over the next 12 weeks as part of that work, because I've lodged this in. It's gone in here now. It's not going to leak out the other side. Right? So,
I was going to say exactly the same, Chair. It's lodged in here with me now as well, so I'll make sure it is fed in. But I just wanted to really say it's great to hear that work's going on in Cornwall. Similar to you, Ash, we successfully rolled out a very similar model in Mid and West Wales in very, very rural coastal communities, so it can work in very remote areas as well, as because I think there's always some argument with these sorts of models that they work well in high, populated areas, but not so much in rural areas. But there are some really, really great examples across the UK of where that's been done really successfully.
this is exciting. Yeah. Thank you for bringing the good news stories and see what you've kicked off. Thank you very much. Okay. Are we done on that whole section? Yes. Looking at the screen, we're all done on that. So thank you very much. So we're slightly ahead of the curve in terms of time. So we're going to move on to item, which is the Section 75 agreement for aftercare, which Leighton is leading on, who's on the screen. Leighton, we're in your hands.
Yeah, thank you, Chair, and good morning, everybody.
So I'll take it as read for this report because it's also been through numerous committees, but we are here for final assurance today. And this is to bring a proposal to bring formal Section 75 agreement between Cornwall Council and NHS Cornwall ICB around the joint funding of a Section 117 aftercare for adults. The proposal, we have an obligation to commission this service collaboratively. I think historically this has been done and through a tremendous amount of collaborative and hard work over the past 12 to 18 weeks to get to 18 months, sorry, to get to this position. We are in a place now where this proposal brings together the joining, which is we are required to do under a Section 117 for this service. And this is a collaboration for it to be led under a joint assessment, but to be led by the council. There's been extensive reviews undertaken to look at what benefits this brings and understand some of the deficits in relation to inconsistent eligibility decisions, incomplete registers, delays and fragmented commissioning. So through a very detailed piece of work to pool this funding to bring some financial benefits, but more importantly, to really drive a much greater service and provision for these patients. It's factored in around growth. It's looked at how service improvement plans will be delivered, and it's pulled the funding from a 50-50 cost share to just under £42 million for the position for 25-26. The centre's proposal has been through numerous committees, and I understand was signed off by council leaders yesterday. And we've already started some of the work around the appointments of posts to take the lead on this. So recognising this is a tremendous amount of work, like I said, but a massive step forward under the Section 75 arrangements to bring a further collaboration of service between council and NHS services. So I'll keep it incredibly brief in relation to what that is. I think the approval we're looking for today is the approval to progress to this collaboration model under the Section 75 partnership. Note the 50-50 risk share and some of the mitigations that have gone in place about recognising growth within that. Note the work that's gone on with the service improvement plans and standard operational procedures, and then just to seek the delegation of authority to myself and council, Section 151 officer, to do the final work. Thank you. Excellent. Thank you. Debbie.
Yeah, could I commend this piece of work to the board? Having been the lead for Section 117 arrangements when I was indeed a commissioner, it's actually a really, really hard, painstaking piece of work that takes absolute collaboration and cooperation and co-design between the local authority and the ICB. So I really welcome the piece of work, but also I welcome the impact this will have on patients and the fact that we've got standard operating procedures that will hopefully improve the discharge and the pace of discharge and reduce the length of stay that I referred to earlier in my partner member report. So a big thank you and well done to both the council and the local and the ICB for getting it this far.
Yeah, I think really welcome the work and very, very supportive. Just a couple of things I think as the work progresses to note. One is something, I think it's in the report around the visibility of the variation in Section 117 numbers. It's just something that probably needs to be addressed in terms of then sort of baking that in. And then the other one was we've talked about out-of-area placements both being positive but equally a significant challenge across the peninsula. So I suppose, Leighton, there's a risk that if that isn't addressed, it's going to become a risk as part of this agreement. So it's probably just something that needs to come back to in terms of, are we making an impact on out-of-area placements in the way that we would want to, because it has a knock-on effect.
So, Leighton, can I just ask, is that any material change to what's on the table?
No, it's not, Chair, and it's multifactorial to address the out-of-area placements, and this is one of the aspects, as Debbie's rightly pointed out, that will go as a tool into driving this, but it's not the sole aspect that will bring the improvements to out of areas. But most definitely, it's something that will happen.
Okay, thank you, Emma.
Thank you, Chair. I'm hugely supportive of this. It was a particular issue around the potential opportunities afforded by increasing a focus on personal health budgets and direct payments, which I note is in the report. We know from evidence across the country, not just in Section 117, but this is an area of some significant evidence that where people are taking individual service funds, PHBs or direct payments, that they are often more financially effective and spent in a way that delivers better outcomes for people. So it would be good as we move ahead with the implementation of this new agreement to look at where we can maximise opportunities around increasing PHBs and support for people to take those funds in more creative and innovative ways than might just be a kind of clinical opportunity. And I would say this, but there's also opportunities, I think, to think creatively about VCSE engagement as delivery providers in supporting personal health budget opportunities.
I just wanted to ask a point for clarification, if that's all right, Chair. So, Leighton, the numbers, just help me with the numbers because I couldn't understand the methodology used, because you said the demand is growing and the amount we've spent for 24-25 is 45.9 million, if I've got this right, and then 1,342 are known sort of cases at the moment and 444 are being catered for. So those are the numbers I was working with, and yet the proposal is for a lower number. And I just couldn't square that circle, if one could say that. So it goes back to Rachel's questions about the numbers. And also the secondary question was, what level of tolerances did you allow for to ensure that the number that you're asking us to, you know, approve as a pooled budget is sufficient for future demand? Thank you.
Thank you. So a very question I went first to as well when we went through this paper, because as you said, there's a reduction there. And that's been tested back through with the team that developed this, and their assurance levels comes from the work that's been done on the improvements that need to be made with the service improvement plan, with the standard operational procedures and the governance that sits around that. So they have debated that element and come to that proposal that they will see there is improvements through the collaborative approach that this will drive. So it's something that needs to be acknowledged and monitored as this progresses. That they have also put within the development of this, and so that there is a recognition that growth will continue. And I think we've put a 2 to 3% improvement growth assumption on this moving forwards. Now, clearly there is a process in place through the governance of this for a quarterly assessment and review to understand if it's delivering the efficiencies that we're expecting and understand growth and the benefit assumptions. And that will, of course, be closely monitored through the associate committees that oversee that delivery. And we're bringing the exceptions, but they have gone through growth. They have gone, because you're absolutely right to point out, we've seen a significant growth year on year, and then there's a proposal to reduce. So noted, absolutely. But with the safeguarding, the safety nets in to monitor that moving forwards, like I said, through those collaborative quarterly reviews.
Yeah, Calvin.
Completely supportive that the paper should have come here, given its strategic nature. But just a question around, before we sign the agreement, governance question, it might need to be signed by the Sovereign Commonwealth and Isles of Scilly Board as well, because we talked about how contracts sometimes need that separate approval.
Leighton, help me here.
I don't think I can.
I get involved in lots of contracts.
No. That's why this is the fantastic thing about a unitary board. Thank you for that observation. What do you suggest, Philippa?
So I think that we have the constituent members of the Cornwall and Isles of Scilly Integrated Care Board sat around the table, and that the Joint Committee was designed specifically to enable these types of issues to be taken at this committee. and that we agreed when we established this joint committee, known as the South West Peninsula Board, that we would only retain to the separate integrated care board decision-making in respect of setting the operational plans for the year ahead or number of years ahead, and specific governance questions. And I think this falls within the remit of what can be delegated to this committee.
Do the Council for the Isles of Scilly need to sign this off, I guess, is the supplementary question.
The council?
Yeah.
They did yesterday.
The Council for the Isles of Scilly?
Oh, sorry, I thought I heard that from Leighton, but Leighton can confirm that.
So I know it was done through a Cornish council. I think we just need to make sure we can take further clarity to make sure the Isles of Scilly were included within that decision yesterday.
Ewan?
Yeah, it's important to remember that the Isles of Scilly have their own health and wellbeing board, so they have got their own separate decision-making processes, so you will have to check that.
Yeah. So, thank you, Kelvin. So I think when we get to this, is there a timeline issue, Leighton, for this approval?
This is the last element of so yes, there is, because we want to enable this from the 1st of February from a way forward. So we can certainly go back to the relevant groups to understand and seek the assurance of where the Isles of Scilly Council have been involved in this and that they've signed that process off.
Okay, so are we saying this is signed subject to the Council for the Isles of Scilly signing this off? That's actually what we're saying, isn't it? Yeah.
Either that or confirmation that they have already signed it off.
Yeah, one or the other. Okay, so when I get to the recommendations in a second, I'm going to try and tweak that a bit. So let's move to the recommendations, if that's okay with everyone. Yeah. No, I can't.
Oh God, no, sorry.
Oh. It was a thumbs up. Oh, you mean a hands up? I thought. Oh.
Sorry, Robin.
No.
Can we just be clear for this, because this has been so long in the process.
Yeah.
That if the board chooses to sign this off, we've signed it off with Cornwall Council. We will absolutely check that we've signed it off with the Isles of Scilly as well. I don't want. I'd really rather it wasn't held up any further, and we're very clear about what we're doing today.
Yeah.
Sorry.
Okay. So what I'm suggesting is that if there is a formality that has to be signed off by the Council for the Isles of Scilly, then we can give our endorsement. Cornwall Council can give its approval and its endorsement.
Yeah.
But if it requires their formal sign-off, it has to either go away and check that's been done, or it has to go away and get it. I'll go away and get it. That's what I'm trying to get to.
Yeah, no, absolutely. I just want the clarity on that.
Yep.
Thank you.
Thank you. I will get there. Okay, so the looking around the table into the points. No. Okay, so let's move to the recommendations. To approve the establishment of a Section 75 partnership for a pool budget of 41.736 million for financial years 25-26. Yeah, I was going to say. So detail is important, isn't it? For 26-27, yes? Leighton, yes? Right, so it's for 26-27. Note the 50-50 risk share and Cornwall Council as lead commissioner. I assume the Council for Isles of Scilly would be supportive of that? Leighton?
Yeah, I think that's part of the assurance back with them for their sign-off. We'll be sure to pick that up.
Okay, so this is assured. This is a decision noting, on the basis that the Council for Isles of Scilly would endorse this, is that we're noting the 50-50 risk share and Cornwall Council as the lead commissioner. Everybody happy with that?
John, can I just check? Apologies, I thought it was for the 25-26 year. I thought this was taking effect from February, so I'd understood that it was 25-26, and I just clarified that with Leighton. But if we could just check that for clarity.
Leighton?
So you are right, Steve. It is implementation from the 1st of. So there is a parallel process running, but it's implementation from the 1st of February this year.
Okay, but you can't spend £41 million in the next 6 weeks, can you? You're talking about starting from 25-26.
Starting within 25-26.
Yeah, but actually spreading over into 26-27.
But this will be a recurring basis, John, of that ongoing budgetary.
Okay, so the 41.736 is a per annum budget. And
so that's the expectation of spend from year to date. So that's the forecast item from year to date spend.
So Simon, you may need to help me here, Simon. How much of that would be proportionate in 25-26? Okay, so we're having to go back to basics, I'm afraid. It says here 41.736 million for financial year 25-26, and my point is you can't spend all of that in the next 6 weeks, 8 weeks. So if that's a per annum budget for 26-27, it must mean there's a certain proportion of that that's going to be spent from 25-26, or is it from now for 14 months? I'm unclear. Leighton.
So John, my understanding is that's the expected forecast item for this year based on year-to-date spend for 25-26.
So what are you asking for 26-27?
I haven't got a number straight to hand, but it's a consistency of ongoing budget.
Okay.
So it doesn't bring an enhancement.
No. Let's go back to the full papers then. Martin, can you help me there?
I think it's set out in section 13, John. It sets out forward financial modelling, section 13, 41.7 million in 25-26, and sets out the forecast for the following 3 years.
Okay, so it's the recommendation that's wrong. It's not wrong, it's incomplete. Yeah, it probably should say to approve 47.36 million for 25-26, and the spends as in item 13 in the paper for the following 3 years. Leighton, I'm only trying to help. If you want to correct me, I'm very happy.
No. So the spend for 26-27 is 43.3 to 44.5.
Exactly.
So it's right in that assumption.
Yeah. So am I saying we're asking this board to approve this year and the next 3 years?
That's correct.
Yeah. So there is a change to the recommendation. Are you happy, Company Secretary?
Yes.
Okay, cool. Sorry, I'm a bit of a pedant. I'm going to go over it again. So the recommendation is to approve the establishment of this for the 41.736 million for 25-26, and for the other following 3 years, as in the paper.
Yes.
Happy with that? Very happy with that? Lovely, good, well picked up, thank you. We've picked up the note for the 50-50 risk share with Cornwall Council as the lead commissioner. Opa?
Can I just ask that the risks are articulated where there are risk shares and things like that? They're not in the paper at the moment, but I think they ought to be moving forward.
So you would like clarity on that? So if we could say, we note that, but we ask for clarity for future years. Happy with that? Okay, thank you. Note the development of the Section 117 policy standing operating procedures, data sharing, impacts and appointment of the pooled fund manager. Everybody happy with that? Good. We take assurance that proposed arrangements meet the obligations and strengthened integrated commissioning. Yep, done. And a bit of a tweak to the delegated authority. The delegated authority to the, can I just add ICB Chief Operating Officer? Because you could have read that. That was somebody in the council, which I don't think they've actually got one, but I think you mean us there. Yeah, so it's the ICB Chief Operating Officer and the Section 151 Officer to finalise the Section 75 agreement following completion and the readiness of the review. So, and can we just add subject to the sign-off of the Council for Isles of Scilly? Everybody happy with that? Okay, we got there. Well done, everyone. Perfect. Thank you so much, Leighton. So, moving on. So we're moving on to board assurance frameworks. Philippa, we're in hands for both of these, but let's start with Cornwall and Isles of Scilly.
Chair, if you're happy, I thought I might start with some remarks relating to both VAFs.
Okay, yeah.
And then go to the Cornwall Isles of Scilly VAF and then Devon. So I think it's important to recognise that we need to continue, as we've said before at this meeting, that we need to continue with both individual board assurance frameworks, or BAFs, for both individual organisations while they continue as sovereign organisations. But I think it's also important to recognise that we need to do work to develop a cluster BAF as well. And I think it's become increasingly important to do that work when you look at the BAFs as they're set out for both individual organisations. And we've said this in the paper, that having reviewed the BAFs recently, they don't feel like they really reflect the strategic risks that we're facing as a cluster and as individual organisations at this point in time. So what I have launched this week is a piece of work set up for in advance of the next 2 board meetings, whereby we have an executive risk workshop and to consider our risk before we come to our board meeting on the 26th of February, and we will have the risk conversation that we didn't manage to have in December. So the board will be asked to give its views on risk appetite and risk tolerance levels and an initial view on strategic risks, having had that executive work fed into it. And then by the time we come to our next public board meeting in March, we will be able to bring proposed set of strategic risks, which will talk to our cluster context, but also align the 2 BAFs for both organisations. I think it's important to recognise that there may be risks that sit on either organisation's BAF that are slightly different, but we will then have an aligned approach. And underpinning that strategic risk work, we are undertaking risk work across both organisations to align our approach to risk management in both organisations, so that will feed into that work as well. So I think it's important to flag that piece of work before we start talking about the detail of the back, because I suspect that a number of the comments from board members might be that it doesn't quite feel like the BAF risks are reflecting the risks that we are experiencing as a cluster at this point in time. To go to the Cornwall and Isles of Scilly BAF in particular, I'm not proposing to go through the detail of it, but I'm happy to take any questions that any individual.
I was going to say, if you feel there's a fundamental reshape, what value is there in going through the 2 at the moment?
So that's why I'm proposing not to go through in detail. If anybody has any particular questions or concerns in terms of... So I think it's important to provide assurance to the board that we continue to maintain our risk management processes and we continue to have risk discussions. And we are actually in the process of looking at how we can, certainly in Devon, move towards a system view of risk and system view of assurance and a system board assurance framework. I'm sure we'll start that work with Cornwall colleagues as well as we move forward. But at this point in time, I think that the BAF can provide assurance that we continue to maintain assurance in respect of some key strategic risks, but I'm not confident at this point that it's all of them, and that's why we need to do that additional piece of work.
That'll become even more self-evident as we move through the next few weeks, when we end up with one cluster management team. Yeah, I get that. Okay. Yes, I was going to come to your good self now.
No, thank you for that. I just wanted to add that we also need to feed into that mix risk appetite and our understanding, develop a sort of shared understanding of what our risk appetite is, not at just a ICB level, but at, much more granular level. And also, I think the other end is we have in Devon residual risk score, and I think that gives perhaps a little bit of false assurance to people. Just sometimes say, well, yes, that's, we're happy with that residual, but I don't think it's meant to do that. So I think it's, again, trying to reach a shared understanding of what is our tolerance of a risk residual score. Thank you.
Rachel?
I think there's something about, and again, even within board paper, about the various organisations within each of the systems reflecting what their top risks are. Goes back to your point about it might be helpful within a partner report context to also just, I think you've asked this actually, what are the key risks what are the top 3 risks facing this organisation at the current time? I think that's a cross-check and triangulation with what the BAFs might say as well.
So would it be an idea to note what you've said and then come back to this maybe next month, or when's your expectation to have that?
Yes, thank you. So thank you for both those points. Absolutely agree with them. So board members will recall we were hoping to have a risk discussion at our board meeting on the 11th of December, which we unfortunately would run out of time to have. We still need to have that, and that covers shared understanding of risk terminology. So that would address Lopa's point in relation to residual risk and toleration or treatment of risk. It would also cover thinking about our definitions in respect of assurance, that we would then be thinking about how we share those. And I've already, again, started to share those with company secretary colleagues in Devon. And we'll be reaching out to company secretary colleagues in Cornwall and Isles of Scilly. So I think the timeline that we are looking at is we have our next board meeting and the board risk discussion on the 26th of February. We have our audit and risk committee meeting on the 9th of March. And we have a number of board assurance committee meetings in between then and our board meeting in public on the 26th of March, at which point I anticipate we'll be ready to bring back fully re-articulated risks, having had board conversations around risk appetite, board significant risk, having had the opportunity to bring partner members to feed into that conversation, having had discussions at committees to articulate what we think the strategic risks across the cluster and for both individual ICBs are, and then we will be able to go away to work out the controls and mitigations to sit under those.
Very good. Okay, a couple of observations from me. That is a piece of work which I think I've understood is actually between the two ICBs. Yeah? If I come back to the Pricewaterhouse work that was done and their recommendations, I've got a couple of questions on the back of that. One was that we have an aligned nomenclature between ourselves and with them. First of all, where are we at on that, please?
I'm going to steal Lopa's thunder on this. So I've been supporting Lopa in arranging a meeting of the Audit and Risk Committee chairs across the cluster.
Right.
And that is due to take place on Friday. And we will start conversations at that meeting in respect of that particular piece of work. I've already started sharing that with company secretary colleagues as well. So we've gone from an executive and we're now going in at the non-executive
So does it
side.
feel like a reasonable expectation by the time we get to the assurance process across our sovereign boards and ourselves as we get towards the end of March, that when we say assured or partially assured, everybody's using the same nomenclature? That's what I'm hearing.
Yes. That's what we're trying to achieve. Yeah, that's the aim.
Can I just reach out to the NHS partner members in Cornwall and the others? Sam, do you agree with that, or is that just an ICB aspiration?
No, I agree. So we've already discussed at our board and accepted the recommendations from the PwC report. So are waiting for the meeting, in effect, to then formalise what is the language we're all going to use consistently.
Thank you. And Steve, from a Cornwall and Isles of Scilly perspective?
Yeah, I think we support the principle, John.
Lovely, thank you very much. And just on a wider context, just remind me where we are at in terms of all the recommendations that came out of that PwC review. What's the process that's going through?
So I think in light of the intertwining of the recommendations coming out of the PwC and the work that needs to be done in terms of planning, my recommendation is that we aim to, when we bring the plans for approval, that we bring a formal articulation of our responses to those recommendations alongside that.
Are you happy with that? Are you happy with that? Sam?
So the tricky bit is actually the individual provider plans will not be coming here for approval, will they? So we need to make sure that the individual providers have completed the PwC recommendations. So we just need offline to work out how we square that in process terms.
Yes, and to provide assurance to Sam and the board, the company secretaries across Devon have agreed to start meeting weekly to make sure that we're aligned in terms of what we bring to our boards in this, and that we're working to the same timescale. So we've started that work now.
Just before I bring Lopa in, because I'd appreciate your comment on what I'm about to say as well. Just because the provider board gives assurance, we can't naturally assume that this board will just say, tick box, move on. I come back to where Tarn started. There's an element of being cited on the level of granularity of detail that if we don't have that assurance, even though if your team feel it's okay, if we don't, we're in a broken circle. So we're going to have to work through how we collectively have assurance, because this board won't give assurance. Our commitment that we all need to sign up to in this board is, if we get to a point where we can't sign up to assurance, we shouldn't just say we've been asked to, so therefore just tick the box. We have to actually genuinely believe that. And I think if we don't exit today with that concept, then we'll be wasting the next eight weeks, and we'll get to a point where one of us will turn around and say we're not doing it. So I'm going to go Frank and then Sam first.
So I take the point that we're going to be sort of looking to merge the BAFs in the future, but if you look at page 147 and the scores for Devon for now, it doesn't feel like it reflects the changes that have happened in the last few months. The numbers have stayed the same since June, and we have become aware that our position has deteriorated significantly. Do we not need to actually reflect what it is now as well as the change? Because those numbers, to me, don't feel at the right level of risk.
Yes, please.
I agree. Which is why I think we need to do this urgent piece of work to make sure that we're actually we have a shared understanding of what the risks are, because I worry that might be what's underpinning the failure to move the scores. But very happy to take a direction from the board that the risk should be considered as much higher rated.
Yeah, and one of the things that we're going to end up doing, and this will be in the pro tem position we've got, this is with Susan and Libby, but with the support of Philippa, there is something about making sure that the ownership of those risks at an executive level before it gets to here has gone through, as opposed to a tier 3, tier 4 person who's done it and we just come straight through to us. So we need to get into that sort of executive management team, it's my language, probably assistant executive group or whatever you call yourself. I think you need to, with your seat, you need to be able to give us an assurance this has been through the 2 executive groups, or increasingly the 1 executive group, before it gets here. Is that all right?
Yes, absolutely, and I can give assurance that it has been through both executive groups on its way here. But I think, I guess my concern is that the pace and the level of work that everybody is
that's a fair challenge.
Experiencing means that it may not have the level of focus.
Very good. Sam?
Yeah, it was just back to your assurance point, because this is complicated, isn't it? Because my board is going to look for assurance that the ICB board has sufficiently scrutinised its plans, because there are a number of metrics it hasn't delivered this year. And then vice versa, the ICB, this is where I'm putting on multiple hats, the ICB board is going to look for assurance that my board, the RDUH board, or the provider boards have sufficiently scrutinised their plans, because there's a number of metrics they haven't delivered this year. So it's how do we get the two-way exchange, isn't it? That is the tricky bit.
I completely agree. And that's why the next 12 weeks, even though we're now into week 1, all right, we can't get to week 12 and then have 2 saying yes and 1 saying no or whatever. We need some early staging. I know you know it, I just wanted to rehearse it with us all. If we get to a point where any one of the teams is beginning to feel unassured, the sooner we raise that, the sooner we can get everybody back on track. So I'm assuming with your chief executive meetings that you're having, you're raising these types of issues. And so we have to get to week 12 and then go through the sovereign boards, including this one, with assurance levels that we're all signed up to a deliverable plan that we promise each other is deliverable with a granularity that we understand. All right, not one which is, I hope it comes with high risk as well, because that is a get-out clause which we cannot sign off as an ICB. That might be a different risk assurance level in a provider, but this board is going to need more assurance at a granularity level that what it's going to say it will deliver. So I just want to say that. Anything else you want to add before we move on?
No, it's just to echo what you've said. But I think what we need is a change in culture of how risk is managed, which is exactly what you've said and what Frank said. Because the risk doesn't reside in the BAF. The BAF is just a reflection of cumulative risks, and the risks resides with you, wherever you are in the organisation, within the team. So I think we need to try and embed a good risk management culture within the system.
Yeah, Philip?
So 2 pieces on that. I, again, completely agree. And as part of the alignment of the 2 organisations' risk management processes, what we're doing is making sure that we're rolling out a risk management training programme for all members of the organisation. Obviously, we need to think about the timing of that, but I think it's very important that we don't let the equivalent of planning blight hold us back when we know we have to do this work. So we've developed a programme at 3 tiers for different parts of the organisation on that. So just to respond on that, I think the other thing that I think is important to recognise in terms of thinking about shared understandings of assurance levels is also the action that needs to be taken depending on the assurance level that is reached.
Yeah.
And that's something that we're incorporating into our work as well. So if a board is unassured, or if a committee is limited assurance, what does that mean needs to happen next? Okay. I think that's really important.
Good challenge. Frank?
Well, it's just about the sort of 3-year to 5-year financial planning, and to a certain extent we're doing. Devon have to do one, and Cornwall have to do another, and yet within 15 months we, in theory, are the same organisation. And it's how do we get from we're both still responsible for delivering against our own financial plans to merging in a 3 to 5 year cycle. I mean, it is incredibly complex.
It is. It will be easier when we have one cluster management team. Okay. I've got a question I just want to throw out there. I don't know the answer to this, but we're talking about strategic risks at our sort of level here. But some of the risks in terms of alignment of clinical risk, some of the decisions that have been taken in front of house that sit in both Steve as on this board and Sam as yours, some of those clinical risks, if there is a low threshold of, we're not doing anything kind of thing, that has a cascading effect over here. How do we get within this risk portfolio some of the clinical decisions such that if one team says, I'm going to lock it down and I'm not going to move anything clinically, and then over here, somebody else is prepared to be more so. How do we, over the next 12 weeks, get some sense as to shared clinical risk? So we'll go Sam first, because I was looking at you when I said that, and then we'll go Peter.
So as part of the work that we are now about to embark on over the next 12 weeks, we have agreed up front that it needs to be clinically led, and that the CMOs and the CNOs, supported by external support, will be part of the driving force behind that. Right. And that we will put our organisational badges at the door. So I think when we're doing the strategic piece, we're very clear about that. I think there is a scale of ambition conversation that we might want to have back at this board. So to give you an example, yesterday I was challenged about there is another system that is exploring moving chemo delivery to 80% of that to be delivered at home next year, compared to currently 8% in that system today. Mm-hmm. And that is a clinical risk type conversation, isn't it, about how far do we want to go, and we probably need to unpack where do we want to have that conversation. Exactly. And then there is the here and now operational risk conversation clinically that we're having, whether we're in primary care, acute care or mental health, about how are we dealing with that operational risk that our clinicians are seeing on a day-to-day basis. And really so I think we probably need to chunk it up.
Really helpful. Peter?
Yeah, so for me, I think it's really important that it is the same process, because otherwise there is a danger that clinical risk is seen as separate to the total strategic risk, which, as you are saying, John, it is the same thing. So for me, it is about the BAF understanding the strategic clinical risk appetite for the delivery of our population health ambition, and then that being intrinsically linked to a system approach to risk appetites that is collegiate and collective, which is what Sam has described.
Very good. Penny?
And so we start to describe the link between the equality quality impact assessments and our risk management arrangements, and that needs to rapidly mature. But I think we've got a really good bedrock in order to do that. So number one, collegiate but healthy tension in the clinical leadership space, enabled by the strategic direction and frame, and then the effective processes around risk management and EQIA. And I think that's something we can rapidly mature as we do the risk, hopefully the risk seminar, explore the connection.
Okay, really helpful conversation. Yeah. But I think what we're trying to embed here is that that's got to be embedded over the next 12 weeks, such that by the time we get to the end of this, part of the assurance is going to be both a clinical and a complete total overall sign up by us all. Okay, looking at everyone. Where would you like to take us? Because there's lots of actions on here. We've got a different set of decisions to make.
Well, hopefully not, because I knew the work was in train when the papers were signed off. So if we look at the Cornwall BAF first, obviously we're talking about the asking the board to agree the current principal risk, but we're also asking the board to note the work that needs to be undertaken.
Okay.
So I think that covers that.
Everybody happy for us to agree with those?
Happy with that, and we'll make sure that the minutes recognise the fact that the reason for this work being undertaken is to ensure that the BAFs in both organisations reflect the changing concept.
Everybody happy with that?
Yeah.
Loba?
Sorry, just based on our earlier conversation, is it for the board to agree the current principal risks, or are we just really just noting that these are the current risks that have been identified by the organisation? Sorry about the pedantic.
For the board assurance framework, it is ultimately the board's responsibility to sign off the BAF. It's proposed by executives, and that's why it goes through the executive team. But ultimately, the board has to be happy to accept the BAF.
Okay, so everybody happy with the agree and note under the Cornwall and Scilly BAF? Yep. Lovely. Do you want to take us through the Devon one?
Thank you. So again, the recommendation is to agree the latest iteration of the BAF, but the additional recommendation in relation to NHS Devon is previously we had suggested that we would undertake some work to align the BAF to the, the health and care strategy that was approved. We haven't been able to progress this work in light of the changing context that we've been going through. But I feel that this will be picked up in the work that I've articulated already in this meeting, and so that should be sufficient.
Okay, thank you. Everybody happy to take those recommendations as they are? Rachel?
It could just be noted that the risk scoring hasn't changed since June and probably does need review in the light of the discussion, so I think that's got to be part of it.
Yeah, absolutely. And I think what I've also heard is that there's some discomfort in relation to the level of the risk scoring as well.
Yeah. You happy you've captured what you need there? Right, let's move on. Thank you very much, everyone, on that key discussion. Leighton, what time is it? We're just slightly ahead. You've got 15 minutes, my friend, because we need to be on time today. Please take us through. We've had a good read of the documentation. What would you like to tease out before we move to the recommendations?
Yeah, thank you, Chair. So I will keep it short because colleagues have touched on some of the key principles I want to bring out through Debbie, Steve and Susan's conversations. So I do just want to recognise that some of the data as normal within the IPR, some colleagues may be feeling it's somewhat out of date just around reporting aspects, and what's in report does reflect October, November, but just through delays and reporting mechanisms. So I think it's really, and I will touch a bit just verbally on what's happened since then, because it's important for our winter pressures as Steve's reflected. And I think maybe I'll start with that and the level of, I think if I reflect back of what last winter looked like to this winter, and I use some data narrative from December for that, all of our UEC matrices we've moved into that winter pressure period, we've seen a positive move from. So even if I just take some of the key ones, we saw a CAT2 response time of 76.9 minutes in December 24, compared to 36 this December just gone, which saw an average handover time of 153 minutes compared to 44 minutes this December. So I recognise this isn't the paper yet because of time constraints, but I think it's really important just to note that while there's been some really challenged operational days, we have seen a marked improvement year on year of improvement. And a lot of that, as Susan's already alluded to, is the increased utilisation of our community assets. So we've seen our single point of access in some of our admission attendance avoidance schemes reach record numbers of activity levels, and we've seen our hospital at home old language virtual wards reach an occupancy level that we've never been to before. So we haven't resolve this on a sustainable basis, but we are most definitely have been on a journey of this winter so far, touch wood, not seeing the pressures we've historically seen. So I think the context is important just to reference as other colleagues have. Just going back to the report then, I think key elements to bring out is we've got a few areas that are still not compliant to our planning aspect. The biggest one of those where we've got the largest deficit is around our 4-hour ED management. So while again improving, we are slightly off our trajectory and the direction of where that needs to be. I must note and bring into that our type 3 performance, which is our minor injury units and UTCs, continues to deliver exceptional performance of generally over 95%. So we must thank the activity and the dedication that goes into them. We've seen a 3-month improvement going up to the November data set on ambulance performance. That's in relation to handovers and CAT2, and they are just marginally outside of plan, but delivering incredibly well. For 12 hours in department, so I think this is the one that we see an area of improvement needed, and that continues through flow, last words, continues through flow through the hospital. And the great work that's going on within RCHT around the focus there, but we are still seeing around about 15% of all admissions spend over 12 hours in our emergency department, and a target we're dedicated to improve upon. I think in relation to conclude UEC urgent care provision, the area that remains one of focus. So while we keep the focus on areas of reducing attendances, admissions, attendances and conveyances, and that spans through our out-of-hours work, primary care work, which have done some great stand-up this winter with additional clinical capacity. Our non-criteria to reside position is one that we all have a little anxiety around still, because that number's greater than we would want. So again, although we have seen a 3-month-on-month reduction of that number, it still brings us some operational challenges, and that spans into mental health as well, to factor into our out-of-area placement numbers. So there's a new dedicated winter cell for discharge management. We see new processes in collaboration with the council that are all very welcomed, and we have the new, is currently out of tender, the new work that's on around D2A delivery from April. So there's lots of progression to bring that to, but we would be adverse not to note that our number of non-criteria to reside across our acute and community infrastructure is most definitely not where we want it to be. If I just move on briefly to other aspects around elective care, so continuing to deliver very well above plan, and I think it's important to note how well we benchmark for RTT delivery within RCHT. I think on the last look 2 weeks ago, we were 12th in the country for RTT delivery. We are improving. We haven't eradicated all long waits yet, but they're in single figures for 65-week patients, but they continue to reduce. Slightly off plan for cancer, but we are seeing improvements across that. And within November, we saw a marked improvement around diagnostic delivery, noting that we have seen the opening of Camborne and Redroof CDC, which will be a fantastic asset to Cornwall, and we start to enhance the utilisation of that provision. As Debbie's picked up on some of these bits going into the planning return, we see some challenges still around long community waits, but we have seen some improvements again around reduction in those delays. And I think I've got nothing really more to add around the mental health aspects that Debbie's already picked up. There's improvements that continue around urgent dental work, and we've seen great engagement around the procurement process that we put in to enhance that service, and close working relationships remain with NHS England on that development. Just around some of the aspects that were picked up around the quality aspects, so stroke does remain problematic for us in relation to the whole pathway delivery. While we've got the Stroke Improvement Board, there has been a newly established oversight group and we've been seeking some help from ESIST to undertake some demand and capacity management and put some more focus around the stroke pathway. But those are the key bits, thank you, Chair, that I want to pick up. I will hand over to Simon for financial aspects.
Simon, you go next, and then we'll open it up to the floor.
Thank you. Yeah, I shall, as usual, on this one, be brief. Yeah. Thank you, colleagues. Can you hear me now?
No, tried it. That's it.
Well, I'm not used to it up here, but go on. Apologies. Thank you. Yeah, so I'll be brief. Firstly, just to underline, we continue to forecast break-even position, and I think all organisations in Cornwall are comfortable with that. I say it with recognising behind that is a huge effort. So whilst we continue to be in that position, and yes, it's year 4, there's massive effort involved by every organisation to get to that position. Recent moves such as further support for IS funding has been helpful and contributed to the position. But the organisations work well together to deliver and share issues across the patch. So we continue to be in that position for 25/6. And I'm going to leave it there, but happy to take questions, John and colleagues. Thank you.
Any questions? No? Yeah, Rachel?
Martin.
Sorry, Martin, yeah.
Yeah, quick comment if you like. When we talk about the previous thing and planning going forwards, I did jump to no criteria to reside, thinking, oh, that might be one where it's going to be difficult, I think, to... Where we've had difficulty in the past, Illumity talked about this, is having a target that we say is going to be X, and then unfortunately we don't meet it. And I just wonder where we've got key targets like that going forwards, rather than just having a sort of assumption and we think this is what it's going to be, and it's either high risk or not high risk, to have some sort of downside scenario where we can sort of say, actually, the range is this, and if it is at the lower range, this is going to be the impact, whether that's financial or knock-on impact on beds and therefore delivery. So we can sort of nuance it a bit when we come to our planning discussion next year. But I did want to also say that, and Neil will back me up on this, we did have some really good results coming out in West Penwith, where we had neighbourhood teams actually going into the hospital pre-Christmas to look at their lists of no criteria designed patients and actually pull a significant number of patients out in pretty short order. So I think there are some green shoots, if you like, or new ways of working that might help with this. And, you know, to me, who's someone's constantly been bashing the team to say, can you show us delivery and can you show us money coming out? I did want to sort of raise that as a real positive thing that we have seen in the committee.
Just before I ask Neil to comment on it, is there anything that you would like to see as an action that comes out of what you've just said?
Well, I'm preempting some of the discussions we're going to have in the planning going to next year, actually, and just thinking, you know, picking up on Sam's point, how are we going to square this circle of different committees wanting different levels of assurance and probably having some conflict in some of those things?
Yeah, for sure.
And one solution might be to have a range and what impact that range will have on the different organisations.
Cool.
So we sort of quantify that.
Well, let's pick that up later on. Did you want to add anything? Or are you just happy with that comment? Could you hit the microphone for me?
Many will know of it as a MAID event, a multi-agency discharge event. I was speaking with colleagues in Penwith about it yesterday, and it was something like 75% of patients in a ward home within five days, and none of them over a 2-week period had come back in again. And it was the key thing was so many people were involved who needed to be involved in that event, and there is a lessons learned thing going on, which I think Juliet Ferris is leading on.
Very good. Tom?
I think we need to move it from events to a constant way of working.
Yeah.
Really, because if this is the effect that it's having, then this is the thing that can really fundamentally change our system.
Did you want to say something, Rachel?
It was more broadly about the performance report.
Okay, can I just deal with this?
Yeah, do that, yeah,
Thank you. Stuart?
Yeah, so just to reassure colleagues that we are building on that MAID event. I myself have been into RCHT on 2 different occasions with colleagues from RINT to support taking patients out, and there is, you know, no doubt that on any given day we've facilitated a number of discharges. It does have to be quite carefully thought through, and I think it sort of comes back to this sort of clinical risk situation that we were discussing earlier as well. You can't share clinical risk without good relationships, and so whilst I appreciate it's easy to say let's share clinical risk, it does mean investing in actually those relationships between colleagues, clinical colleagues, and so there is still a little bit of work to do on that. But our first wave INTs are all actively engaging in hospital in reach at the moment.
Very good. Steve?
Oh, well, what Stuart's just said is the shorthand. I think the impact here on facilitating discharge, but also on admission avoidance, is really significant. And I just wanted to thank all colleagues that have been involved in enabling that. And I think the point Stuart's just made about the critical importance of strengthening further relationships, trust and understanding across the whole system is going to be a really important part of our work going forward. And we're working closely with National Association of Primary Care, which are directly involved in helping to support some of the transformations across the whole system, including that aspect of culture and building trust.
Great. Don't answer it now, but Libby, as you're leading on this in Devon, we lodged something else in our brains earlier on that was a key shift of an idea. This feels like another one. All right. Can you think about how this gets taken and brought into the 12 weeks worth of work? This is where, with general practice and primary care being at the heart of the left shift on both Cornwall and in Devon, but we'll come to Devon in a second. So, Frank?
So I go back to the point of the local authority trialling having a 24-hour carer in the person's home. It's about risk appetite and how much risk is there in doing that, and can we stimulate it as quickly as possible? Because I don't think there's that much risk if there's someone on site. And then you don't have to have absolutely everything in place. You can, a lot of it's around them anyway. So can we progress that idea as quickly as possible? Because when they're in hospital, you get blocked just waiting for a bed in a nursing home. Their bed is available. It's just a case of finding someone to be there with them. They want to go home. They'll be better managed at home, and all the community services are already there. So it's, we were talking about the clinical risk. I suspect there's not that much once their medical problem is solved.
I guess what I'm asking is, can that be input into the next 12 weeks piece of work? Rachel?
Yeah, I just so I think the board has really good visibility of the issues and the narrative is really strong. I think I'd probably just say there is the so what though that is and maintaining the discipline within these performance reports of the action is being taken, but by when do we get it on back track? And when I just look through, I don't see a lot of when are we going to see the impact of the actions that are being taken, that are articulated, when are they going to have an impact? And I know that's difficult in some cases, but I would just encourage colleagues to keep that discipline, because that board knows by when what's going to happen and when do we expect. And I think to that point, mental health is a particular area of concern for NHS England and Cornwall at the moment, partly because we don't have the visibility of the by when. And so I just ask that perhaps at the end of the year the board look at where things have, despite everybody's best effort and all good intention, have not been able to address the issue. So it becomes a sort of intransigent fixed issue, or whatever's happened hasn't. So it's a bit, I think it's helpful for then the board to reflect on. And I would say talking therapies is probably one of that in Cornwall, where it remains a challenge. There's been significant investment. There's been lots of great ideas, but it's not moved. Okay. So what's stopping that happening?
Okay. Dan, did you want to come in first?
No.
No, fine. It's Neil. Yeah.
John, you just mentioned the issue of could we embed that kind of risk process in the 12 weeks? Yes, and we should try to aspects of it. But I'd like to make the point that one of the key drivers, and NAPC are very definite on this, and they have data that states that the biggest impact in terms of outcomes on the type of work we want to do, shifting work to the community and looking at how we manage risk. And I will say, one of my colleagues who I respect greatly uses the word shared uncertainty rather than risk, which is a lot less pejorative term, is that psychological safety working within teams is the biggest driver. And that's why I keep going on about getting people working together again. It goes back to managing risk in the way that I did as a young GP. I used to pick up the phone and share it with colleagues and share it with people in teams I knew. And that's what we've got to get down to, and that's why the whole thing, it's not just, and I'm seeing headlines nationally that say 10-year plan isn't going to work. If we go through an embedding teams approach, we're going to get there, because people like working in teams, they work better in teams, and they manage risk better in teams.
Very good. Sean, and then we're going to move on.
Yeah, just to summarise that, if I may, with a good news piece of work which can encapsulate some of the discussions. Colleagues know that nationally, sepsis is one of the leading cause of avoidable mortality, and it's causing up to 48,000 deaths in the UK annually. What we have commenced in the latter stages of 2025 was a deep dive of the management of sepsis across Cornwall and the Isles of Scilly, given our rural challenges and how the challenges in terms of Cat 1 and Cat 2 responses, and also timely access to antibiotics, which we know saves lives in the earlier treatment. That has resulted in a significant piece of work that's been implemented, and I know many colleagues are aware of this, but essentially it has engaged stakeholders across primary care, microbiology, our emergency department and our ambulance services. And I just wanted to recognise that they've looked at the NICE guidance and the UK Sepsis Trust, who's helped us undertake this work, as we wanted to be innovators in terms of that engagement with our neighbourhoods. And what we've now done, as of last week, received funding to implement the grab bags across primary care, so that actually as GPs who wish to be involved in this process, may I add, as part of our sepsis working group that we've now developed across the peninsula, there's both Devon and Cornwall and the Isles of Scilly, is actually the sepsis grab bags are going to start in Cornwall in the first instance, but essentially GPs can commence that early blood cultures, IM antibiotics or IV if appropriate, and actually commence early treatment in the community, so that when individuals get to hospital, our PGDs, the antibiotics that we're treating people with, are now all the same across Cornwall, whether they get given them in the primary care or whether they get them in the emergency department. The microbiologists have come together to agree those PGDs. But essentially, we are now accepting that we want everyone to have timely access to treatment. But ultimately, when those individuals, not just about saving lives, but it's about if they have sepsis, that timely onset will help them get out of hospital should they recover from their sepsis in the most effective way. So I just wanted to flag that as a key piece of how system partners have worked together to identify an issue that hopefully will save lives.
Thank you. Great, let's move on to Devon. So, John.
Thank you, Chair. The paper you have will attempt to triangulate finance, performance, quality reporting. I think recognise that these papers have also been through our finance and performance group. So I'll highlight the key issues. Penny, Peter, and Simon will contribute as appropriate, actually, and then we can take any questions. So in terms of summary, in terms of month 8, the position shows a sustained fragility and deterioration since month 7. Finance, workforce spend, urgent care performance, RTT performance, no criteria reside, are adverse to the Devon ICB plan. A number of quality risks persist, including those around maternity, mental health, infection control, and CHC. The risks in the paper are mainly concentrated at the Royal Devon Hospital. Our deficit support funding and the cash position are creating further fragility at Torbay and at UHP. The worsening underlying position relies on currently non-recurrent mitigations, and thus we need a clear plan for a month 9 reset. With particular reference to performance, our main challenges, but not limited to, no crowd to reside, ED, particularly paediatric performance, mental health weights, and infection control. These challenges or these main challenges subsequently reinforce financial pressures, thus higher bank spend and our substantive spend and increased length of stay. In the paper, we detail an action plan that covers over 2 to 3 weeks, 30 days, and 60 days. Thank you.
Okay. Anything to do with Devon finances?
Your mic on.
Sorry, put your mic on.
Yeah. Just to reflect back that, as Sam referenced, the overall position deteriorated at month 8 with the movement at RWH. So the overall position that we're seeing in the forecast, so I'm going to quote this without DSF, is a circa 92 million deficit for the year. It's easier to compare it with the deficit numbers, so ignore deficit support. That compares with the 53 million deficit position that we submitted and got support for at the beginning of the year. So the deterioration obviously has a big impact on our position. And it's important to note, as we have these discussions over the next week or so as well, that position impacts on our ability to improve in 26/7. So one of the numbers that you won't necessarily see in this report is we recognise and we've seen a deficit position across providers, underlying deficit position deteriorate by about 74 million. Of that 74 million is an added issue for 26/7 that we need to address. And you can start to see the accumulation of issues building, a problem that really does need to be addressed, and that's where we need to get to in the discussions tomorrow and over the next couple of weeks with the support of PwC.
And we'll pick that up this afternoon. Any questions, colleagues? Yes, Tom?
I suppose what I'd like to hear is whether this was at month 8. Now you were looking at a month 9 reset. We're now nearly at the month 10. Is there any indication of any of this moving?
I think we'll get into the detail of that. I think this is a good update from Simon at the moment. I think it's, if you recognise the two numbers, the 53 million and the 91, gives you the magnitude of what's happened in year and what in year has done potentially for next year. One of the questions we'll be talking about later is quite what is the ICB's commissioning position. But let's leave that for later because that's more substantial. We'll stay on this. Any other questions, Jennifer? Yes?
Given the MAID event in Cornwall, did we have a similar MAID event in Devon?
So it's a really good question. So we have in place in terms of no credit to reside, particularly in North and East, where the biggest challenge it is, a leadership compact led by Penny, Sam, and DCC. So that's out of the MAID event. There are a number of key actions which we all believe and understand are held by all organisations and not one organisation. As acting coup, I take those actions forward actually through the governance which we've reinforced through the support of Newton through the North and East system. So we have a leadership compact that owns the outputs of that MAID event, which will support and oversee the operational changes we need to take place in the next 10 weeks. Or Penny, if you'd like to contribute to that.
I think you said it.
Well said. Very good. Steve on the screen.
Yeah, thank you, John. Section 11 sets out a summary of the cash position, which is helpful. I just wanted to check, can we have an update on the request for cash support for the two trusts? And is there anything we need to do as a board to kind of further escalate those matters for support?
The requests, thanks for the question, Steve. The requests have been submitted and we're expecting the support to be provided. So it is being managed, and both UHP and RDOH are expecting that cash to come through to support this year's position.
Okay.
Thank you.
Everybody happy? Well, I wouldn't use the word happy. Yeah? Everybody understanding of where we're at? Yeah. And everyone's under huge pressure. I get that. We've just got to, at some point, do something different to what we're doing now. And we'll spend this afternoon talking about that. Okay. So in terms of what we need as actions that come out of that, so in terms of the Cornwall one, IPR we had from Leighton, are we both happy to note the performance issues reported on the financial position? Cornwall, yes? Everyone happy with that? Yeah. Yeah, good. And in terms of Devon, slightly different ones. The action is to note the triangulated deterioration and concentration of risk at RDOH and the implications this has for the system delivery. Okay. Approve the month 9 reset and recover requirements and the deficit support cash strategy. Do we really want to approve that? I'm looking to you, Simon. Are we?
It probably does need to be approved and supported because the cash position needs to be supported nationally, etc., etc. So we need to approve it. Doesn't mean the board's happy with it.
Okay, so approve and not happy. No, sorry, I shouldn't joke. We'll approve it, but we're noting the position on that. Okay. Now, do we take assurance from the time-bound actions and enhanced oversight approach articulated within this report? Would you say we're taking assurance?
So I'll look to John on performance and Simon, but I'm assured from the COO's perspective that from a performance perspective we have the necessary oversight arrangements in place. And similarly, in the context of the enhanced escalation that we're going to be talking about a bit later around the planning for next year. But I think that has to be within the wider context that we have just commenced this week a 12-week programme with some additional support from PwC to reflect the fact that actually we do need that additional capacity and capability. So I think that may change, Chair, but at the moment I'm content that what we have in place.
So what I'm going to bring in Graham first, then Rachel, and I'm going to just throw this out there. I think at best we can probably move to taking limited assurance, but bear with me on it.
So we look at the contract review report in FPQ, and we also look at quality reports on a regular basis. Yeah. And one of our observations is that getting assurance for the entirety is just too big a piece. Yeah. So we tend to break it down into individual stages along the cycle. And so when we've looked at this, we are satisfactorily assured in terms of the adequacy of the data collection, although there are some gaps in it, the quality of the analysis of that data and the format of its presentation and our ability to understand it. We also assured around the number of actions, although a lot of those are around meetings, and there's a limit to the value of meetings, I would suggest. Our concern has been and remains to be whether the agreed set of actions translate into delivery.
Yep.
So that just breaks into the individual parts, if that's helpful.
Lovely. Rachel?
Yeah, I mean, I think just firstly, this is about this year's performance. I don't think I've seen anything today or heard from the committees that there's any assurance that the board will achieve its 25-26 plan. We talked a lot about 26-27, but this is about the plan that was signed off at the beginning of the year. Is it going to be met? So the answer to that would be, I don't think the board can be assured as yet that it would achieve its 25-26 plan, but there are actions in place. And as you say, Chair, limited assurance about the impact of those actions at this stage.
I think we can go further. The plan that was set back in April, we know we're not going to.
So you need to say that now. It's month 9. This is where positions are baked in. Excuse me.
So, but that's the reason why I actually said, can we take assurance? Really?
Just to be clear, when I provided my report, I did say no assurance. Okay.
Yeah. So that's where I was coming at. I think so. Simon, I just need for you to be really clear with us on here. Is that when we use the language of take assurance or limited assurance error, whatever, I think we're able to sort of say is there was a plan. That plan we're not going to achieve for 25-26. Let's just call it out, yeah. But what we're now getting as a new number that you've talked about, is there a belief then that we're taking some form of assurance, even if it's limited, on that new number? Okay. Would that be acceptable to be sort of minuting as from your seat?
Yeah, I mean, I think there's the finance aspect. Yeah, there's a new number, etc. But I think there's the performance, the overall performance and quality aspects as well.
Yes. Sorry, thank you very much. I was going to deal with the money bit first and then come back. So, Graham, help me here.
Well, oddly enough, I think I've got a higher level of assurance on the financials, albeit it's being plugged by non-recurring, than I do on some of the performance metrics.
Okay, so that's why I'm going to try and chunk them up. So on the money bit, I think help me capture this correctly. I think what we're saying is we're going to state here and now we're not going to achieve the plan. but there is a new number that the team have been speaking to each other about and with Region about, and that number is now locked in, and we have a higher degree of assurance that that plan will be achieved. That higher degree, the reforecast will be achieved.
So your satisfactory assurance?
Satisfactory assurance. Would you buy that? Yeah. Would everybody else buy that? Oh, great.
Well, just to be clear, I mean, numbers reflect activity.
Yeah.
So the mix of the things that we are going to exit out of the year is not the position that we want to be in. So whilst I can say that financially the level of assurance outcome I have reasonable certainty of, the mix within it is probably not what we planned, and that is a reflection of the difference of the activities that have been undertaken. So the two are linked. So I just want to be clear of it, that we're not just separating out the money on its own.
Okay, but from a money perspective, because I'm going to try and do money and then metrics, from a pure money perspective, there's a new number. From what we've seen, there is a belief through the committee and everything else that's gone through that that new number is going to be achieved by us as an NHS-wide system for 25-26. Would you buy that as a minute? Are you happy to take that? Leighton, I hope your point is on Cornwall and not on Devon at the moment, because you're going to really confuse us if you are. Can I come back to Cornwall in a minute? Yeah. So on Devon, the money bit we've just talked about, I'm hearing from you not the same degree of assurance or potentially even limited assurance on metrics. So can I get, from your seat, what is your view of the quality metrics?
Limited.
So you think it's limited? And that's what Philippa was just saying to me. Would you buy that?
Yeah.
Would you be happy to take limited assurance from what we've heard today from Devon on the quality metrics?
So can I just confirm, are we talking quality or performance?
Performance. Sorry, I did slip a bit there. I agree. Sorry.
I was going to say performance.
Yeah, I need lunch. That's the thing. All right. On performance.
Yes.
You're happy with that?
Yeah.
Can I? Sam?
I agree, limited.
Yeah, limited. Can I just ask the clinicians in the room also? Penny?
So, Chair, I want to come in on the quality component of the report. However...
Bear with me, I'm just trying to do this in bite-sized chunks. So I was wrong when I quality. On performance, would you buy limited assurance?
Yes,
and
noting the quality impact of that.
Thank you very much. Can I turn to Peter?
Yes, I'd agree.
Thank you very much. John, can I turn to you? You agree as well?
I think if we could just add, I do agree, right? But what provides that limited assurance, actually, if that's the term, if that's what we're going to agree on, in terms of the timing of these reports, I think it is really important, particularly around some of the really important, I think, performance markers like RTT, is that we are fully engaging in a number of sprints that have been supported by NHS England around outpatients, RTT, independent sector, cancer. And in terms of the, as we report through the committee in due course, actually, those are the levers that we will use in the last 10 weeks, actually, to look at, if it's limited, basically. But as I said, we have really good opportunities to end this year in a much stronger position than we are now.
All right. I'll come to Frank in a second, but Penny, you wanted to say something about quality?
Yes, so I think this is the first time we've brought an integrated finance, performance and quality report. What we need to do as a piece of learning, Chair, is to reflect on what's the quality component of this report, because that should relate to operating plan and so forth, and the quality impacts of the financial and performance position. What we've actually included is broader information, and I wouldn't want there to be limited assurance on those aspects.
Okay, so here's what we're going to do. For next time, both for Cornwall and for here, we need to split out the reports into 3 chunks: money, performance and quality, and take a degree of assurance or not assurance or limited on each of those. Right?
I do agree totally, but when you talk about performance, what you actually see in the detail are that some service lines have actually been performing very well. So let's not get ourselves into everything's terrible. No. However, as I said earlier, there are some intractable areas. So 4-hour wait at A&E, mental health, children, maternity services, RTT. So there are elements within the entirety of the services that have proved very, very intractable. And those are the ones that I have highest concern about, because whilst we are working the problems, we've yet to crack them.
I'm going to try and wrap this up soon. But before I bring in Lo, because I think yours is a Devon question, I know that Leighton's is a Cornwall one. Is yours a Cornwall one, Steve?
No, apologies, mine's a Devon one.
Oh, yeah, that's why I jumped to you. Let's go for it then. Devon one, yeah.
Yeah, I'm struggling a bit to kind of be aligned on the assessment of the financial confidence for Devon, not because I necessarily disagree with it. I just don't feel I've got enough information, so I'm not quite clear whether we're asking for that assurance to be given at an ICB cluster level or a Devon system level, but not being involved in some of the detailed meetings that some ICB colleagues have had. I'm not sure I've got enough information to have that assurance.
Why don't you share that as a thought, Philippa?
I think that the board has established an assurance committee for both, one for Devon, one for Cornwall, to consider the issues in detail.
Yeah.
And at this point, it should be considering the steer of the chair of that assurance committee.
Very good. Frank?
Probably comes from being a simple GP, but I'm quite confused as to the new figure, as to whether that is exactly where we think we are now, and we rely on improvement when a lot of the performance is getting worse, or whether the new figure is
let's just
projected
park
to
it for
the
a
end of the
moment.
year.
It needs a lot of quality discussion, which we're going to have as the day goes on, so 100% there. But let's just take Philippa's advice. Let's go to the Devon Deputy Chair, who chairs the committee there for finance, performance and quality. Can you give us your assessment of what you think we should be minuting here?
Okay, so I think we agreed that we're going to unpack it into finance.
Yeah.
And I think we're saying that we are assured around the overall number for the forecast. We were unassured about the previous number, but we have now moved that through a defined process through month 9, which has gone through region to a new number, which Simon has already highlighted. So I think we are assured around the delivery of that number. I can put risks on it. We all know that there's risks, etc., etc. I think when we come to the quality piece, I think we are assured. I think when it comes to the performance piece, we are assured around some of those service lines, but not against some of the others. So in aggregate, it comes to a limited assurance position.
Very good. I think we're very clear. For Devon, let's pause on that one. I think that's a very good summary. Lopa? There was a clue in what I said. It was a very good summary.
I don't want to. It's a very good summary, but I just want to highlight that a limited assurance, there are implications, and I think those need to be discussed, which I know we will.
Yes, we will. Okay. So that's Devon concluded on that element. You're holding us from lunch, Leighton. No pressure, my friend. On Cornwall.
Well, I just want to come back to reference, because I know comments from Rachel around actions and timeframes to deliver, and I take that. But I just want to give assurance further around where we are against the plan in Cornwall. So I think I covered some of those aspects in my verbal narrative today, but we do submit a very detailed document within our IPR, and every aspect is referenced against our plan and where we are against that plan and the actions underway to deliver that. So I take the point around timelines and reflections, but our IPR is very detailed about our position against plan.
Okay, noted. Thank you very much indeed. So I'm going to move us on. Do I need to make any?
I think
we're noting everything.
No, I think we've also noted an action in relation to presentation of reports in the future.
Very good. Thank you very much, everyone. Helpful discussion. I think our member of the public has gone. I was going to turn and welcome a question, so there's no questions for that. Is there any other business? So in terms of time, let's come back at 22:02, if that's all right. Can we make it sharp? I hope we'll finish at 4, but let's make sure we're back at 20:02, and then we'll have a good go at it. Thank you very much, everyone. Let's close that meeting now.
Yeah, just to say, post the conversation of the section 117 discussion, I've had clarity that this is only in relation to Cornwall Council, and this isn't applicable at this stage to the Isles of Scilly.
Okay.
So further work will be done in the year to progress this with the Isles of Scilly, so only Cornwall Council.
Happy with that? Anything we need to tweak or whatever, or just note that comment?
We can put a drafting note in there.
We'll put a drafting note in. Like, you're a star. Thank you. Thank you very much, everyone. See you at 22. Thank you.